for inviting me to join all of you today. It is truly an honor to be with you all again. Like Dr. Dudley said, I know that we wish we could be together in person, but that's still not safe. But I do want to let you know we're seeing a light at the end of this long pandemic year. As I've said, the light at the end of a long, dark tunnel. As you probably are aware, cases have been going down and vaccinations are going up. It's just a couple of numbers. 2 days ago, we put 72,000 shots in arms. The day before, 78,000. So we're ready to go in Virginia. It's, you know, if they give us the doses we need, which actually looks promising, the current administration has opened things up. Our allotments are improving, and now with the J&J, vaccine being approved, we should be in good shape. And I don't want to give any definite timelines, but I'm hopeful that by early to midsummer, the majority of Virginians will have been vaccinated. And I know that everybody is anxiously waiting that, and that it won't be too long before we can start doing some of the things that we used to do. For now, though, we still need everyone to do what we know works. Wear a mask, social distance, and wash your hands, and have meetings like this virtually until we get this pandemic behind us. And speaking of doing the things that we used to do, I really miss taking care of children and their families, and I look forward to being back in the healthcare arena in 2022. While it has not been a normal year, we are continuing our work to make Virginia's perinatal, maternal, and infant health system one that is a model for the nation. COVID-19 has brought challenges that have tested us in ways we could have never imagined. And it has put into better focus many inequities that we already knew existed. So I want to thank you for your work and your commitment to serving Virginia's moms and infants through these unprecedented and challenging times. I'm glad to see that moving the Virginia Neonatal Perinatal Collaborative from the Virginia Department of Health to VCU has gone well. The transition has strengthened the partnership with hospitals and outside agencies by expanding and enhancing collaboration, while still working very closely with the Virginia Department of Health. This wouldn't have succeeded without the VDH team in the Office of Family Health Services and Shannon Purcell, and I am immensely grateful for their work to protect mothers and babies across our Commonwealth. In the fall of 2019, our office conducted 10 maternal health listening sessions across Virginia. Time and time again, we heard women speak about how the lack of respectful care at the individual, system, and structural level has a negative impact on the healthcare environment and maternal health outcomes. We heard women tell their personal stories about the impact of racial and cultural bias, impacts we see reflected in the data. We also heard that women and families want more choices for maternal care providers and their pregnancy support team. And we heard that our current reimbursement models do not allow for the full range of choices. Women supported by a midwife or doula, and those who had access to home visiting services during and after their pregnancy reported positive birth outcomes and experiences. This group knows better than anyone that it takes a village to support new parents and their babies. Midwives, doulas, and home visiting programs are a crucial part of that village. We know there is a need to place greater emphasis on the mental, dental, and physical well-being of women in the postpartum period. We also must focus on reproductive justice, ensuring women are empowered to choose when and if to have children. And finally, we need to get the basics right. Every community needs access to safe housing, affordable and reliable transportation, and nutritious food. We held that listening tour in 2019, and we have continued to work to implement what we learned and improve maternal and infant health in Virginia. For example, we heard women praise the experience and support they had with doulas. So we worked within our Medicaid program to make sure doula services are covered for mothers who receive Medicaid. 1/3 of babies born in Virginia are born to mothers covered under Medicaid. This doula benefit means that pregnant women in Virginia will have another layer of support. We are continuing to work to address implicit bias and cultural competency in the healthcare setting. The Department of Health Professions and VDH are working together to develop a health equity training for medical students focused on increasing awareness of implicit bias and providing tools to prevent inequitable outcomes due to bias. We all share the goal of improving the health and well-being of Virginia's mothers and infants. There is power in every child, and we want all moms and babies to get off to a great start. We couldn't do that without the work each one of you does. And so on behalf of Virginia, I want to thank you all. I look forward to continuing to work together, and I hope you have a wonderful rest of the summit. So stay safe and healthy. That goes for you and your families. And thank you so much again for inviting me to join you. Thanks, Dr. Dudley.
Thank you, Governor Northam, and thank you for taking time out. I know it's just at the tail end of the General Assembly, and it's been a busy several weeks, and I appreciate you taking the time to come welcome us.
It is. It's interesting, Dr. Dudley. We have had a fast and furious session, and a lot of the folks are so worn out. I haven't even seen them come into work today, but I showed up. So, but anyway, we had a good session, but we're ready for a little breather. So thank you.
All right. Thank you very much. Shannon, can you pull up the agenda, the schedule real quick, please? Just like to summarize for everyone what we're going to be doing this afternoon. After that, gracious welcome from Governor Northam, Dr. Governor Northam. Stephanie Spencer will tell us a little bit about the Merck for Mothers grant that was recently funded by the Merck Corporation. While not specifically addressing mortality specifically, it is, I think, a great opportunity for everyone here to learn about the program. It's been a great collaboration between the VNPC and Urban Baby Beginnings that Stephanie and Shannon have put together. So this is a really exciting opportunity, which hopefully will be a model for the state. Then after that, Dr. Melanie Rouse, who's the Maternal Mortality Projects Manager, will give us some updates on some of our data and what we're seeing in the context of maternal mortality and any other data that she may be sharing with us. And then we'll transition to Tammy Ziegler, who will talk about perinatal palliative care and describe their program at Mary Washington. We will then have a break and resume at 3:05, regardless of the timing of when we get done with the first half of the agenda. We'll start at 3:05 because there may be some participants that are waiting specifically for that. And then we'll have a panel with 3 faith leaders representing Roman Catholic, Jewish, and Muslim faith expressions, as well as a hospital chaplain. Discuss cultural and faith aspects of maternal, perinatal, and infant loss. Doesn't matter where you come from or what faith expression you have, everyone suffers loss and suffers grief. And how these faith expressions and cultural aspects kind of drive, if you will, behavior, or at least inform behavior, will help us to take better care of our patients. And so hopefully it'll be a great opportunity to really begin to seek to understand our patients better and provide better care for them. Then we'll have an open discussion, and that will mainly be through the chat box that people can put in questions, and Shannon and the panelists will be able to respond to questions as is appropriate. And then we'll wrap up at the end of the afternoon. So as we said, this is a very diverse and hopefully we will find interesting program. So perhaps we can go on and transition into Stephanie, if you're ready, Stephanie, and we can discuss the Merck for Mothers initiative that you'll be rolling out here. So we're a few minutes ahead of time, so you can kind of take your time.
That's great. Thank you for the introduction. Thank you to Governor Ralph Northam for bringing us in and talking about the importance of infants and mothers and their children across the state of Virginia. This has been a whirlwind year in terms of maternal health efforts, and we're really excited to be a part. I wanted to take the opportunity to talk a little bit about our project called Project Rebirth, Building Sustainable Community-Based Programs and Safer Childbirth Cities Throughout Virginia. I am Executive Director of Urban Baby Beginnings. By trade, I'm a registered nurse. I do have a lot of background in building community-based systems and also in public health. I'm very excited to be a part of this work to share how important it is to include community and to build systems in community to improve outcomes overall. I'd like to also introduce one of our key partners, Mother Health International, and give Rachel Zaslow an opportunity to introduce herself as well.
Thank you, Stephanie. I'm Rachel Zaslow, and I'm a midwife and Executive Director of Mother Health International. At Mother Health International, we work specifically with community health workers around the world to address barriers to care and implement collaborative care systems. So it's been an honor to work alongside Urban Baby Beginnings and through this Merck for Mothers grant to be able to develop a community-led program that we hope to model and scale throughout the state. And so Stephanie is going to share all about it now.
So a little bit about Urban Baby's mission is to reduce adverse outcomes and isolation experienced by families. And this is during the perinatal through early childhood years. And we do this through increasing professional and paraprofessional health access, social support programming, and also addressing systemic barriers. Our goal overall is to decrease the rate of preterm birth, maternal morbidity, as well as mortality for infants and their mothers, while also ensuring that our children are school ready through our early development program. Overarching goals for the organization are to increase access to culturally appropriate care through the development, certification, and support of maternal health hubs across Virginia, to also decrease the risk of isolation by providing opportunities for social support. And that's inclusive of doula services. And you heard Governor Ralph Northam talk about that a little bit ago. Also creating evidence-based educational programs with a focus on enhancing parent-child attachment and development. And an example of that is through home visiting, utilizing doulas in the community who are trained and paid a living wage to work with mothers who are at risk for poor outcomes. And lastly, providing training, mentorship, supervision, and support of perinatal specialists through our evidence-based community doula workforce development program. We have several targeted interventions through our program, one being our social support programming, which uses community doulas to support insured and uninsured individuals across the area, providing education through our evidence-based home visiting programs to resource mothers, as well as Family Spirit, which is a Johns Hopkins evidence-based home visiting program. Our workforce development program, I mentioned that earlier about our community doula evidence-based training, and also functional support. One thing that people don't know is that we are the largest diaper bank in the state of Virginia. We've provided 2.8 million diapers during just the COVID instance, as well as we served over 7,000 families. Diapers are extremely important. We've talked about policies to help families in need by connecting them with services such as ours. Just to give you a high-level overview, many of you may already be aware of some of the Virginia statistics. What we know is that the preterm birth rate up to 2018 was 9.41, and the mortality rate for infants was 5.59 in 2018. I wanted to give you a little bit of breakdown by race so you can see the disparities that exist between white, Black, Hispanic people, even non-Hispanic, American Indian, and Native individuals. And you can see here how this disparity exists not only in the preterm birth rate, but also in infant mortality. In 2019, the Maternal Mortality Review Team published a report. It was the Chronic Disease Report, which is available online for you to read. But I wanted to highlight a little bit about what was in that report today. A couple of things that were cited was that just over 25% of women with a chronic disease received referral to a specialist for management of their chronic disease. And that's problematic because we know that people need to have a wide variety of health and health connections and resources to have their best outcome. And what we also know is that among the women who did have at least one chronic disease, 44% of them had at least one provider related factor, such as failure to refer or seek consultation contribute to their death. Just to show you a little bit about what that looks like percentage-wise, we're talking about 15% of people who had a facility-related death in regards to their postpartum period. And facility-related factors, by definition, refer to individual facilities, infrastructure, policies, and the availability of personnel, equipment, and technology. Examples of that would be policies that led to delay, inadequate treatment, and/or inadequate or unavailable personnel or services. When we move into community-related factors, 28% had community-related factor contribute to their death. And by definition, community-related factors include availability and accessibility of services in the community, law enforcement response, community outreach, and availability of subsidized care. And lastly, moving on to provider-related factors that contributed to maternal deaths, 51% of women who died during the period of 1999 to 2012 had at least one provider failure contribute to their death. Some of the most prevalent contributing factors to their mortality included delay in or lack of diagnosis, treatment, or follow-up, and failure to refer or seek consultation, which I mentioned earlier. So then we start to look at the PRAMS data that came out in 2018, and it asked one question, which was very different than some of the others previously. It talked about the level of bias that people had experienced in their care. And in that survey, Black and Hispanic women reported that they had experienced bias at 3.3 to 4 times higher than their white counterparts. And just to give you some indication of what that was in regards to, I've listed that in this chart here. Now let's talk a little bit about Virginia's mothers and speaking. And it was mentioned that the maternal mortality sessions, the listening sessions occurred all throughout the year. Last year, there were 10 sessions. There was a lot of work to be done to understand what Virginia mothers and families were saying, birthing individuals were saying. So we also, for the past several years, have been conducting surveys, and we did a study all last year, just a qualitative study to understand what were some of the things that our families were saying and how did that relate to the care that we provided. And 62 respondents discussed their ways of we could improve the maternal health landscape. So some of their suggestions included a warm line for perinatal information, social support services such as groups, lactation educators, and maternal mental health services, and earlier connections to support such as community doulas and home visiting. Families discussed that the lack of coordinated care, meaning being able to connect to services and it being segmented and siloed, was a predictor for them to having negative birth outcomes and trauma. We also subsequently surveyed 128 community-based organizations working directly with women and children, and they expressed frustration regarding the lack of trained professionals, funding, and platforms to support women regardless of socioeconomic status. So we know that there are keys to well-being, right? We need to have affordable housing, food access, transportation. We need to have high quality healthcare, employment paying us a living wage, and environmental safety. We need to be safe in systems that are anti-racist and free of bias. And we need to have culturally appropriate care and services. And there must be an intentional focus on reducing those disparities. So some people say, well, why Norfolk? Well, Remember what I mentioned earlier about the preterm birth rate for Virginia. Well, when you move into Norfolk, the preterm birth rate was 12.31 in 2018, and the mortality rate in Norfolk was 6.66 for infants. You can see again the same disparity, Black, white, Hispanic, on down the line. And again, I've broken it down also by infant and preterm birth rate. The Maternal Mortality Review Team Chronic Disease Report also outlines some of the challenges by area, and Norfolk is in the eastern part of the state. And what it mentioned was that the maternal mortality rate for those with a chronic health condition is twice as high for those without a chronic condition in the eastern part of the state. And Black women with one chronic condition have a rate of over twice of that of their white counterparts. So now let's talk a little bit about the Safer Childbirth Cities Initiative, which is funded by Merck for Mothers. And it was launched in 2018 to help create a world where no woman has to die while giving birth. And it's a multi-year focus, but this project for the city of Norfolk is 3 years. And it really looks at building community-led systems that help cities become safer and more equitable places to give birth. The particular cohort that we are in is really going to work on identifying local needs to advance evidence-based and evidence-informed interventions which increase maternal health equity. So Norfolk in Virginia has joined another 18 initiatives across the United States to improve outcomes. I talked a little bit about community-led solutions. I want to tell you all about Urban Baby and the fact that we've been in the community for a little over 27 years. So we're really excited to be a safer childbirth city in the city of Norfolk, but we also operate in other areas across the state. I want to give you a little bit of glimpse of our platform. Project Rebirth is a telehealth platform. And what it does is it connects women or individuals of color who are pregnant or postpartum to paraprofessionals of color in a virtual space. It's meant to connect virtually and then to put boots on the ground to ensure that mothers and families have the resources that they need to succeed and to have to have positive outcomes, When we talk about our collaborators and what we're really attempting to do is we want to reduce those disparities. If you all attended the last summit, you heard Dr. Art James talk a little bit about there needed to be an intentional focus on reducing disparities for people of color. So we are going to have a three-pronged approach in looking at that. It's building infrastructures for state and city officials, strengthening community-based partnerships and support systems, connecting people to services by providing paraprofessionals of color, and also raising awareness of the importance of perinatal care. I really like this chart because it kind of shows you that everything starts from the community. It doesn't start from the medical home, the hospital, it starts from the community. It has to be driven by the community. How we have our system placed us into a maternal hub, which allows for people to get connections to resources and information, to be able to have licensed professionals and non-licensed professionals who are all having that same goal of having that healthy, safe outcome for the family and their baby. And this is a systems level approach. I do believe in programming. I think that it is extremely important, but what we also recognize is that from a sustainability standpoint and also a reach, being able to look at a program versus a systems level approach in transitioning how we look at things can affect many more people than it can just in one little pocket. And so really we're looking at transforming healthcare systems and integrating our systems of care as far as social support is concerned into hospitals, clinics, working with community-based providers, working with our managed care organizations. Then we also have community-based systems, which are more so your programs and centers, your family support centers, such as your home visiting, baby care, early intervention. That gives you some idea. Families are at the center. I made that very important, that families always have to be at the center of the work that we do. And then you talk about federal and state policies and programs. So legislation, we've got the Momnibus that's come back out, Virginia doula funding, Medicaid expansion as a whole. All of these things are trying to improve the health and welfare for our constituents in the state of Virginia. So when we talk about this telehealth platform, we really talk about connecting people through 4 different means, to connecting with individuals that have specialty and family resources and engagement. That's more so our community doulas and others who do that level of work. We talk about maternal mental health and having that and building that social support network so that people can be connected with providers in a timely manner. And that's something that's really a challenge. We also talk about lactation support and human milk feeding. That's extremely important for families who want to breastfeed. Most families say they want to breastfeed, but we don't have the resources and connections to ensure that they are successful so that they can feed their babies as long as possible. And lastly, nursing. It's important when you're working with high risk and at risk populations that we always have that connection to someone who has that license so that we can then deploy to other systems if it tends to be something that's emergent, but also making sure we're maintaining the evidence surrounding the care that we're providing. So our overarching goals for this 3-year project with our partners at Virginia Neonatal Perinatal Collaborative and Mother Health International is really to affect systems level change. The VNPC is working on a disparities dashboard and launching that so that we can understand from a hospital perspective and the surrounding areas, what are some of the key drivers to poor outcomes based on social determinants and disparities within those systems. Really working directly with communities to develop and implement strategies to reduce infant and maternal mortality. There are a lot of silos in these systems, and we really want to encourage people to come together because we really are stronger together than we will ever be apart. Our goal is also to develop a specialized perinatal workforce. Again, the mention on community doulas and the funding under DMAS. This is a huge effort for the state to improve connection to social support for families who are birthing and in the postpartum period. However, we also need to make sure that we're training and mentoring new doulas throughout the state. And Urban Baby Beginnings is one organization out of 100 across the United States that provides an evidence-based community doula training program, which is supported by Health Connect One. And this is a huge initiative for us to undergo to really develop workforce for community doulas. And lastly, we want to provide a connection point, a website, a web of support for expectant and postpartum individuals of color. And we want to improve care coordination, increasing access to social support programming, reducing bias and trauma and poor outcomes related to racism and systems. And I'm coming to my closing, obviously, on my on this particular presentation. But what I want to make sure that everyone realizes is that there's a lot of collaborative effort that we're all making to ensure that we make Virginia the best place for families to raise their children, to have their babies. And this is a hospital, legislative, down the line effort to ensure that our families are supported. And so we're really excited to continue to do this work in partnership with several key organizations, but also our community. And so if you are interested in learning more about this and how we will support systems inclusive of hospital-based systems and community-based systems, please reach out. If you don't remember anything about this particular slide, you can make sure that you reach out to Shannon Purcell at Virginia Neonatal Perinatal Collaborative to learn more. I'm the chair of the Maternal Quality Care Alliance through the VNPC, and I want to make sure as well that you all understand that we do have a community-based part of the organization and that we're working to build that. And so if you are interested in that aspect as well, please reach out so that we know, so that we can ensure that we include you in those discussions going forward. So thank you to Shannon and the team for giving us the opportunity to share our work and to share just how passionate we are about maternal health outcomes and making sure that our moms and our babies are very well supported.
Thank you, Stephanie. That was wonderful. This is a really exciting opportunity. We do have time for just a couple of questions. If somebody wants to put a question in the chat box for Stephanie. Before we get on to Melanie's presentation. Shannon, are you keeping an eye out for that?
Yes. So far none. You can also use your raise your hand feature and I can unmute you if you would prefer to do that. We do have a question. Stephanie, where are you all in the process of specifically addressing maternal mental health? And do you want to touch on that, or I can talk about that as well?
I think the question is probably geared towards overall, so I'm going to let you touch on that, and I can add a little bit on the maternal mental health side for the platform.
Okay, yeah, so perfect. This is an excellent segue. We are actually in the process of standing up the 4th trimester patient safety bundle under AIM, Alliance for Innovation on Improving Maternal Health. And we're looking at probably late spring. AIM is in the process right now of collapsing 3 of the patient safety bundles together, the maternal mental health, the delivery to 6 weeks postpartum, and then postpartum with a transition to maternal care, or I'm sorry, women's care. And so they're in the process of putting those 3 bundles together with metrics. And so we will then move into implementation. So look for something around April, May for us to launch that. If you are wanting to participate, please send me an email. We'll make sure you get connected.
And on the platform side, we're working to develop a better network in the Hampton Roads area, but just overall with Postpartum Support Virginia, we've been having a lot of conversations of what that looks like from a paraprofessional training perspective, as well as support on the telehealth platform, as well as support in person. And we know that to build those systems, you also have to have people who are trained appropriately in these areas. And that's just not paraprofessionals, that's also professionals who have licensure, psychiatrists, psychologists, LCSWs. And so really excited to look at this a little bit more closely and see from our side what that's going to look like, especially in the Hampton Roads area. There's a good presence out there. We want to look and see what that could look like potentially in Norfolk. I also see 2 other questions. How many, do we have time to answer 1 or 2? Or...
We have time, go ahead.
Okay, the first question says, what will collaborations look like with the home visiting programs that are currently in the Norfolk area? And we do have connections with the home visiting program alliances, and we're actually working together to figure out what that's going to look like. When I talk about family resource professionals, it's really extremely important that we have strength in our home visiting programs and other resources so that we can refer appropriately. So I'm happy to say that part of our building year, which is this first 8 months, is really looking at how to strengthen those systems so we can also collaborate and refer as appropriate. So that is on the radar, and we're working towards that as well. The second question is, will the grant be used for only doula workforce development or also medical support nurses for at-risk patients, since Norfolk is the hub for patients who are are high risk? So our specialization is in building community paraprofessional workforce and development. However, as a nurse, we have also nurses on our staff, and we do work with them to develop their skills so that they can work with individuals a little bit more closely. That's going to require, obviously, some of your ask is going to require for us to put our heads together to figure out what that may look like to ensure that our nurses also have the support that they need. I'm a big proponent of ensuring that our nurses are empowered and prepared to be able to work with individuals. I will also say that several of the medical schools have reached out to talk to us about what this could look like. So I think that that's an opening segue into much, much more as we start to build. And again, I want to go back to say that this first year, this first 8 or 9 months is really about the planning and implementation of this project. We'll be doing some beta testing on the platform, which will happen just within our team-based environment to work out any kinks. And we'll actually roll this out to the community come about November timeframe. So we have a lot of time. So I appreciate the questions that you all have. And these are really great questions and have come up. And I look forward to meeting you all in these meetings that are coming up within the next couple of weeks. If I'm not on your calendar, or if you've not heard from me, please reach out and let me know, because we are trying to make sure that we're able to meet and discuss with everyone and discuss these types of questions off of this particular site. So thank you so much. I appreciate it.
Yeah, thanks, Stephanie. That was great. I would like to point out that Norfolk is not the hub, it's one hub. There are lots of hubs in the state of Virginia, and the hope is that this will be a model program that we can roll out to all the other places that are managing high-risk patients. So with that, we'll move to our next discussant, and that's Dr. Melanie Rouse, who will give us some data and updates where we are with some of our mortality rates. Melanie?
Right. Thank you, Dr. Dudley. And I'd like to start by saying I'm very excited to hear about the Merck for Mothers grant. Let's see, make sure I have this screen share correct. Yep. Okay, there it is. But I'm very excited to see the impact that that's going to have in the Norfolk area. So today the plan is going to give you an overview of the Virginia maternal mortality projects, and then kind of give you some overall pregnancy associated data updates, and then go through some of the racial disparities that we have in the data, as well as some contributors to these deaths, and then talk about a few recommendations from our chronic disease reports that Stephanie referenced during her presentation. The Virginia Maternal Mortality Projects is funded through the Title V grant, and it has two primary components. The first is the Pregnancy Associated Mortality Surveillance System. And this system tracks the patterns and trends in pregnancy-associated deaths in Virginia related to the cause and manner of death, the demographics of women affected, temporal relationship between the end of pregnancy and death, and the outcome of the pregnancy. The second component, the Maternal Mortality Review Team, performs a systematic review of all pregnancy-associated deaths in the state in order to identify the contributors to death and to identify prevention and intervention strategies. All cases for the Maternal Mortality Review Team are reviewed in the spirit of public health. The Maternal Mortality Review Team process follows the action cycle suggested by the CDC and the Association for Maternal and Child Health Programs. We first start with case identification, which includes all pregnancy-associated deaths in the state, and that is defined as the death of a woman within 365 days of the end of a pregnancy, regardless of the cause of death or the outcome of the pregnancy. Then followed by case selection, we ensure that all those cases fit within that specified criteria. We then abstract the cases with information from all medical records that we are able to obtain, any social services records, any records from any providers that provided care for that woman within the 5 years of her death. And then we review each case thoroughly and review each case for recommendations that can be made to help prevent deaths in the future. Consensus decision-making is used to determine the contributors to mortality in each case, preventability of the death, and the pregnancy relatedness of the death. So we're going to go through some of the 5-year trends in the pregnancy-associated mortality ratio for the state. I will make a disclaimer here that we do not have data for 2014. This was due to some significant errors in the pregnancy checkbox that occurred when there was a transition to the electronic death certificates. So data for 2014 isn't reliable, so that we don't necessarily include it in this analysis. But as you can see, overall from 2010 to 2012, there seems to be a slight increase, and then there seemed to be a decrease to 2013 and 2015. I will say that preliminary numbers for 2016, however, suggest that the mortality ratio increased to almost twice as high at 61.3 for 2016. We're looking at overall pregnancy-associated mortality data. A majority of these deaths occurred more than 43 days after the pregnancy ended. And the leading causes of death were cardiac disorders, followed by accidental overdoses, then homicides, motor vehicle accidents, and cancer. As you can see, about 57% of these deaths were from natural causes, 26% from accidental causes, about 10% from homicide, 5% from suicide, and about 2% were undetermined. Pregnancy-associated death rates for Black women between 2010 and 2015 were significantly higher than their white counterparts. As you can see through this table, the differences was the highest for Black women in 2012, with them having a rate over 3 times as high as their white counterparts. And when we look at the aggregated data for those 5 years, Black women have a pregnancy-associated death ratio that is over twice as high as their white counterparts. We see similar patterns when we break down the ratio by age and race. One thing that is particularly alarming when you look at this graph is that Black women aged 19 and below have pregnancy-associated mortality ratios that are similar to white women who are aged 40 and above. There are also some significant differences in racial differences in manner of death. Black women have higher proportion of deaths from natural causes, while white women have a higher proportion of accidental deaths. Where we really start to see some significant racial differences is in the cause of death categories. Among white women, the top causes of death were accidental overdose at 18.5%, motor vehicle accidents at 12%, and cancer at 12%, followed by suicides and homicides, which were both at 9.3% of all pregnancy-associated deaths among white women. When we look among Black women, cardiac diseases was the cause of death for about 22% of those deaths, followed by homicide and the exacerbation of chronic disease at about 9.9%, and then accidental overdose at 8.6%, and pulmonary embolism was the fifth leading cause of death at 7.4%. Several key pregnancy indicators and risk factors were identified amongst pregnancy-associated deaths in Virginia. The most prevalent risk factors identified included mental illness, chronic substance abuse and chronic medical conditions, and intimate partner violence. Nearly 2/3 of all pregnancy-associated deaths in Virginia had at least one chronic condition, and the number of chronic conditions in each case ranged from 1 to 7, with most cases having at least 2 chronic conditions. The most prevalent chronic conditions included endocrine disorders, chronic mental illness, and chronic substance abuse. Over 25% of pregnancy-associated deaths in Virginia had been diagnosed with depression, and approximately 20% had been diagnosed with anxiety at some time in their life. And nearly 25% of all pregnancy-associated deaths in Virginia were also found to have a chronic substance abuse. Data from the Virginia Maternal Mortality Team reveals that many chronic conditions, including substance abuse and mental illness, are not adequately addressed prior to pregnancy, during pregnancy, or during the postpartum period and beyond. When we look at some of the contributors to mortality that have been found with the Maternal Mortality Review Team, approximately 28% of all pregnancy-associated deaths had a community-related factor such as inadequate subsidy of care or a lack of community outreach or support contribute to their death. Over 50% of all pregnancy-associated deaths were found to have a provider-related factor contribute to their death. And as Stephanie mentioned earlier, these included things like inadequate assessment of risk, a delay in or lack of diagnosis, treatment, or follow-up, and failure to refer or seek consultation. And this lack of these provider-related factors also actually indicate a lack of care coordination, which can contribute to pregnancy-associated deaths in several ways, including a lack of coordination in patient management between providers, breakdowns in communication between providers, an absence of policies and procedures that facilitate coordination of care, and of course, a failure to refer and seek consultations for chronic disease management. Some of the patient-related factors that have been identified as contributing to mortality include chronic medical conditions, mental illness, substance abuse, non-compliance, and a failure or delay in seeking care. Through case review, the Maternal Mortality Review Team has been able to highlight several opportunities for the prevention of pregnancy-associated deaths among women in Virginia. Our most recent report focused on cases with chronic condition, which had been found to be a significant contributor to these deaths. And the team found that coordination of care was a significant problem in these cases. And in order to improve coordination of care among this population, several steps would need to be taken. This will require both a refined approach to clinical care of pregnant women and to strategies that can be deployed at the practice and system level of care delivery. Strategies should include policy changes, education campaigns, and trainings that address the lack of routine health care for chronic diseases outside of pregnancy, the limited availability of specialists and women's health providers in rural areas, the need for the provision of nutrition and dietitian services in pregnancy due to high levels of obesity in this group, and also the interoperability of medical records. Some of the key recommendations from our chronic disease report include that all providers of care to women of childbearing age should be trained in and engage in screening, brief intervention, and referral to treatment for substance abuse, as well as screening for mental illness, domestic violence, and trauma at the initiation of care, as well as throughout the care. And also, given that women with chronic diseases have worse outcomes during pregnancy and the postpartum period, we recommend that established prescribed management algorithms for standards of care for the treatment of pregnant and postpartum women should be utilized routinely. These should also include the management of hypertension, heart failure, and hemorrhage. We also have recommended that all emergency departments should have processes and policies in place to ensure that women are screened for a recent pregnancy and that care coordination occurs for all pregnant or recently pregnant patients at the time of discharge. This care coordination should include identification of barriers to care and follow-up care, referrals to community resources to help address these barriers, and communication with the follow-up providers to ensure that providers are aware of the referrals. And you can review the full maternal mortality review team reports and recommendations at the website that's listed on this slide. And as I mentioned before, and Stephanie also referenced this in her presentation, our latest report entitled Chronic Disease and Virginia Pregnancy Associated Deaths and the Need for Coordination of Care is available on the website. That's what I have.
Awesome. Thanks, Melanie. That was a great overview and a great review. There was one question in the Q&A that asked, would it be helpful to separate data findings for failure to refer and failure to seek care?
Yes, it could. And that's one thing that we do look at on our team. And when we're discussing these contributors, we discuss all aspects of that. And so that delay or failure to seek care, it does, while we have that as one contributor together, we do also highlight and discuss distinctions between a delay or failure.
Okay, thank you. We have time for maybe one more question. If someone has a question, they can either put it in the chat box, the Q&A, or raise your hand and Shannon can see it.
I think that's it.
There was one question from Janae Powell. With the data collected, what are the next steps to addressing the mortality rates?
I think the next steps will be taking what we have and working with it now, because it's not one of those things where we can say, well, let's wait until we figure it all out. I think we have a good place to start and we can go there, but we also need to get to better data and more in depth to really fully understand the mechanisms and processes that are occurring.
And this is what we're doing in the VNPC. We completed just recently, and perhaps Shannon can speak to the AIM postpartum hemorrhage bundle that we implemented at about 34, 35 hospitals in the state, correct, Shannon? And also we're going to be, as she mentioned earlier, rolling out the 4th trimester bundle here, hopefully later this spring. So we are actively trying to address this. And keep in mind that when you look at the chronic conditions, and perhaps something if Melanie wants to expand on, the role of postpartum maternal deaths, and not just within 6 weeks postpartum, but I mean within a year postpartum. That's where we're seeing a significant proportion of the maternal deaths due to chronic medical conditions. And that's what hopefully this 4th trimester bundle will address. So we are actively addressing this. With regard to inpatient initiatives to improve maternal outcomes, I mean, different systems have different things ongoing, and that was the postpartum hemorrhage bundle was an inpatient. There are other inpatient initiatives, particularly with hypertension management, that we can entertain, but Our bandwidth is such right now that we really can only manage 2 or 3 projects, and we have a couple of neonatal projects that are coming online as well. So hopefully we can come out with some other inpatient initiatives later. Did you want to expand on that at all, Melanie? Especially the postpartum death issue.
Oh yeah, like we said, about 54% of our deaths occurred 43 days or more after the end of the pregnancy. And, those are also pregnancy related deaths as well. So, we definitely have to start looking beyond just that 6 weeks postpartum period as far as the management and care for these women.
Okay.
Hey, Donald, there's one more question. I don't see it in the panel, but it came straight to me. It said, would it be helpful to separate data findings for failure to refer versus failure to seek care?
We addressed that at the beginning, Joe. We saw that.
Oh, I'm sorry. I must have missed it then. I apologize.
Thank you for being attentive and alert. Is there a public copy of the 4th trimester bundle document? You can find it at the AIM website, but I don't know that they have the 4th trimester up now since they're revising everything. So Shannon's shaking her head yes and no to what I'm saying.
Well, no, they're finalizing it right now. So it's in the final edits. It's actually been submitted to HRSA for final approval, and then states will have access to it. So we anticipate, that's where I'm saying, hopefully April, May, we will start the implementation process. We're supposed to have access to it March, April. So it is real time happening right now. So I promise, once it's available, you all will have access to it.
Okay, thank you. So why don't we move on to the next speaker, and that's Tammy Ziegler, who will talk about perinatal palliative care. I met Tammy at one of our conferences, oh gosh, maybe a year or 2 ago, Tammy, I can't remember it anymore. And we discussed the idea of her speaking at the conference one of these days, and we've actually made it happen. So I'm pleased to introduce her to you. So Tammy, you want to go in and begin your discussion.
Hello, let me get my screen up here. Slideshow from beginning. There we go. So hello, everyone. My name is Tammy Ruiz Ziegler. I haven't been Ziegler for very long, so 2/3 of the time I've been in this job, I was Tammy Ruiz. So I'm the perinatal bereavement coordinator at Mary Washington Hospital. And today I'm going to be talking about perinatal palliative care in community hospital settings. So for those of you who work in a big city referral hospital, this may not necessarily be exactly what hitting the center of your target, but I want you to be familiar with it because there might be colleagues that you have that are at hospitals that feed into your hospital that this might be applicable to. So most of my job entails caring for miscarriage and stillbirth cases. Statistically speaking, they are the most common. So I do most of my work is actually in bereavement care, but there is a smaller segment of my population where the parents have received a grave life-ending diagnosis. And this is more particular what this talk is going to be on. In terms of housekeeping stuff, Shannon is going to watch the question box, and she will have the capacity of interrupting me and tossing out a question in the middle of this discussion if she sees that there's something that she thinks might add to the presentation. So don't be bashful about asking a question. I will add that I have no financial disclosures or conflict of interest. Each family that allowed me to share these photos did so in a very selfless and helpful way, but I do request that you not take any photos of the screen. So they have allowed me to show these photos, but they are not to be used for anything else. So please do not capture any of the images. And please know that in this discussion, I will use the word parents to speak of the pregnant woman who may or may not have a partner. The word parents that I'm going to be using is really essentially for brevity. I think we could have an hour-long discussion of the most perfect words to use. In fact, if you have suggestions for me, but for the sake of this conversation, I'm going to use that word. So today I join you from Fredericksburg. And for anybody who's not familiar with Fredericksburg, it's halfway between Richmond and DC. I gave this talk in South Africa, and I had to I showed a map of the whole, all of North America to show where Virginia was. So I had to take North America off my slide. And our placement along I-95 actually does sort of affect some of our patient population that I'm going to be telling you about later on. So what is palliative care? Perinatal palliative care. It's a program of support after grave prenatal diagnosis where a decision has been made to take a pregnancy to the natural end. And this option is generally used for women, couples, families who've had a fair explanation of all of their options, and they have decided that this is the way to choose to live their story. Again, ideally, parents are given a full, clear explanation of what their options are. And this really, the decision to choose a palliative care option for their baby who likely has a life-ending condition, this really needs to be offered without any pressure or any sort of excess coercion from anybody. It's really something that people ought to be able to choose of their own free will. And I think that we live in our culture is so complex sometimes, and yet in our town we have found that we have a really good system where the obstetricians and maternal fetal medicine doctors work really well with the families to be able to give good, fair explanations of all their choices. When I talk about a pregnancy going to its natural end, this may not be 40 weeks. The mother may have complications that require her to deliver a little bit before 40 weeks gestation, and the time for that is decided by the mother, the OB, and the MFM make decisions about how close to 40 weeks they actually go, and that is very much dependent on the best interest of the physical health of the mom. So what does perinatal palliative care look like? And a colleague of mine who was a co-author on an article that I wrote, and she says it looks like love. I pointed this picture of a dad. I had just handed him his son, and someone snapped a picture of his face, meeting his child for the first time, knowing that his son was not going to live a long life. And the smile that he has on his face of joy of parenthood and love really captures a lot of it. I think when people talk about infants with short lives, so often we only talk about sadness and fear. And yet I find that very often these families will, they're able to really find moments of joy in it. Let's see. So over and over, I've really seen a very natural and beautiful parenting flow naturally in the moment. Sometimes parents will say, well, I don't know what I don't know what I'll do. And I don't know if I'll be able to know the right thing. And I usually tell them to not worry, that it will unfold in its natural, organic way. So I also like to point out that we all understand that NICU care is life-saving care. NICU care and transports to higher level of care are normally the course of action when we find out that a baby is sick. I'm totally supportive of this. Please don't mistake this model of care being presented as discouraging NICU care in any way, or in trials of NICU care. The cases I'm going to be speaking of specifically today are cases where higher levels of care will not benefit the mom or the baby. A city the size of Fredericksburg we will have usually at least 2 cases a year like this. I remember one time there was a brief period of time where I had 8 ladies walking around my community pregnant with babies that were not going to survive all at the same time. That is a little bit unusual. And even though the cohort is small, it can be a really powerful offering to make possible for parents because of how important it can be for them, which is we will get there. So I would refer to this article. In fact, if you have your phone handy, I would encourage you to take a picture of the name of the article so that you can pull it up in your hospital database. It was in the Advances of Neonatal Care in the June 2020 issue. And the article explains a lot of our processes and how we intake families, how we make decisions about which cases will be appropriate. Submitting this to Advances Neonatal Care was all the idea of Dr. Barb Snap, who's one of our neonatal nurse practitioners. And so I teased her that she acquired me an entire year of work on this article. But it's very descriptive of the care. Specifically, I'd like to describe the bibliography of this article. Was very intentional. I joke around that it's as rich as bread pudding with caramel sauce. The bibliography of this article, it shows it's very exhaustive in terms of references involved in the scholarship of perinatal palliative care. There's a relatively wide area of research and scholarship going on in this area, and I would encourage you guys to don't just take what I say, dig into it and learn about it. It's really interesting. So why would a medium-sized hospital offer palliative care for babies when the big city hospitals take care of a lot of sick babies? And here's just sort of a few suggestions that I have. It's a familiarity with their hospital, being at home, is that this local hospital may be where their other babies are born. And if they know that this baby's not going to survive, to be able to stay in their own comfortable setting can be very helpful. If they are in their own setting, they will, during the mom's latter part of the pregnancy, she would be able to experience support of local friends, her church, her family. She can keep her regular OB physician who might be able to deliver this baby, as well as similar to the other babies she's had in her family. Very often, a lot of these families will be encouraged to have, they will want to have photography to record this baby's short life and during non-COVID times. Most of what I'm talking about in terms of having family and friends around is of course in non-COVID times, and we hope we return to non-COVID times soon. But in cases like this, very often a photographer who's a friend of theirs will be able to come in and take pictures of their time together as a family. So our units are like at Mary Wash, our L&D is right next to our NICU, is right next to mother baby. Everything is so small and so close, and everybody knows each other that we can transfer mom from one unit to the other very quickly. If the baby is in the C-section rooms, we can get them to the NICU very fast. We're just very physically close. I know in some big city hospitals, you can have units that are on other floors. This really helps us to be able to take care of this little cluster family that may have some hours of very needy care very well. It's a small community hospital close to home is easier for siblings and family to come and go to visit the family. And I put traffic on there. Why would I put traffic? Well, talking about where Fredericksburg is, we are on that wretched stretch of highway between Richmond and Washington, D.C. We've had families actually who were planning on delivering in D.C. have Plan B deliveries for Mary Wash, because if they go into labor during a non-COVID time, Monday morning at 7 o'clock, they may be at risk of not getting to the hospital in time. So we are prepared for cases where that happens too. So what sorts of perinatal palliative care patients deliver in mid-sized hospitals? For us, it's mostly babies whose prognosis is certain, where nothing is to be gained from delivery at a higher level of care. If parents are still hoping that there's a possibility that a treatment, especially one requiring surgery, is going to benefit their baby, we usually at that point, if they're really still harboring that hope, we really encourage them, no, then you're not really ready for this. That very often the families that we take care of in this program have gone to higher levels of care. They may have been to Johns Hopkins or CNMC, maybe even CHOP, to get detailed assessments of their baby. And when they learn that there's really no possibility of their baby surviving, then they very often will swing back and say, well, if this isn't going to do any good to deliver in Philadelphia, then let's deliver at home. So how can we do this? So the picture there you see is it was a young military family, and they came here from another area. So they arrived here, the mom was pregnant, and she didn't have a friend in the city, and her family wasn't here, her friends weren't here. And one of the first things she did when she arrived in town was to get prenatal care for her baby. She already knew her baby was very sick. And so when she found out that that higher levels of care were not going to be beneficial for her, they decided to have her here. And the family had a tradition that when each baby was born, the dad gave the baby a bath and used a certain towel and a certain blanket. And since they wanted their 2-year-old, who you can see here, to participate in that, I was concerned that if I tried to help to give the baby a bath way up on a table, that the 2-year-old wasn't going to be able to reach and participate. And so we came up with a solution that the dad would give the baby a bath picnic style on the floor. In doing that case, it prepared me more for the next case, for another case that I did. That family that I showed you in the earlier slide, they were a local family from far out from outside of the city, and their local hospital didn't have a palliative care program. They had gotten significant prenatal assessments of their baby and knew that there was no way that he was going to survive. So they wanted to have him out in a local hospital setting. And these were all of the baby's sisters, and they wanted to participate in giving him a bath. And so we were able to bring the whole family in. They were Orthodox Christian. They had 2 priests and a cantor, and they had participated in significant rituals that they had chosen for their baby. And they said it was just really meaningful for them. When I initially ever heard of perinatal palliative care, I had been a NICU nurse for years, and I, at the time, was studying chaplaincy. I was considering becoming a hospital chaplain myself. I studied briefly, and I decided in the middle of that course of study that I liked being a nurse. So I refocused on my nursing career. But I saw an article in a newspaper in Kansas City that said a palliative care program was opening up there. And I was astonished at it was about 2003. When I first even heard the phrase perinatal palliative care and perinatal hospice, it just struck me as a NICU nurse. I thought, well, of course we should do this. I'd taken care of many babies where the mom had walked in to the delivery and said, well, we know this baby's not going to survive. So, and everybody threw something together and did the best they could, and probably did a pretty good job. But it makes logical sense that if you know that a case like this is coming in 2 months or 3 months, why not use your time to best prepare the family, to talk to them about what they might want to do. And so that's really part of what perinatal palliative care is giving the family a chance to know what their options are and make some decisions ahead of time for what they want this delivery to look like. So what conditions do I see most? I really see most like anencephaly, trisomy 13, trisomy 18, renal agenesis, and some previable prematurity, just the common ones. And with regard to trisomy 13 and 18, when I was first doing this 15 years ago, those were quickly discussed amongst people as being universally fatal conditions. And now 15 years later, they're really not necessarily considered universally fatal. There's been a real shift in the way that we look at these kinds of cases. So we need to remember that we are sort of on a never-ending path of innovation with disease treatment, and what was untreatable in the past might be treatable today, or sometimes even there's a change in attitude. So parents who are expecting a trisomy 13 and trisomy 18 baby have become very vocal in the last few years about really more advocacy and really insisting that their child is assessed for potential benefit of more aggressive treatments than were offered in the past. So we're looking at sort of a never-ending improvement in different options that are available. Renal agenesis, a few years ago was just considered absolutely untreatable. And my understanding is there are some studies being conducted in some major centers that will potentially be offer treatment options in the future. But really, even if there are some things way on the horizon being considered, the parents that we're taking care of right now really only have the options of what treatments are available today. So we can only really respond to right now. So we can't really help it. We can't really just hope for innovations for the future to change what we're going to be able to offer families today. So again, we look at that some conditions are unsurvivable. In our culture, that's a really hard thing for us to face. I think also it's very difficult for neonatology because when we look at how the media presents neonatology, they're always talking about the miracle babies, the miracle situations, and that's really hopeful. And I think that can be really helpful, but I think that there's really a lack of understanding in our culture about the limitations of neonatology and the fact that there are some situations where we aren't going to be able to save a baby's life. And I think that's a very difficult path for parents to have to walk when they first realize that this is the situation they're in. I think we all have seen the same experience with families that are having pre-viable babies, and it's sometimes such culture shock for them to have to accept that there may not be any treatment for this baby. And for the staff, it really takes communal bravery to stay steady when you're taking care of a baby with a life-ending, untreatable condition. So often in our culture, we want to find a silver lining in every cloud, and we want to try to find the maybe and the possibilities. And it is not easy when you are taking on a case where there probably are no options in terms of treatment. And you're walking with people who are genuinely expecting a death. And that takes a certain degree of strength and fortitude, and it ends up requiring a really steady team. Our neonatologists really have become real leaders for us in being willing to just be really present and stay steady. I think that they're the way that they, especially the medical director of our NICU, has been pivotal in how he has really helps families to frame goals when it comes to deciding how we're going to handle these cases. And not just the fact that there's no treatment that's going to save their life, but how are we going to treat them while they are alive? What are we going to do with them? So it can be a real healing experience to facilitate babies and families to be taken care of in their own home. If there is no treatment for them, then in some ways it really abandons them when we won't give the family the option to consider delivering them in their own home city, because we're forcing them to go someplace else and to have somebody else take care of them that still won't be able to offer any life saving measures. So we're really staying steady and taking care of our own community very faithfully when we allow them to stay in their own hometown and have their babies here. So I made a video about a case that I took care of a number of years ago, and we're going to watch it at the end of this presentation. I tried to embed it in my talk, and it caused all the technology to go kerflooey, and none of us really want to sit here and watch technology fail. So we opted to take it out of the presentation, but we will show it at the end. I specifically, though, I would encourage you, if you're interested, take a picture of this screen, because where you see for a quick find, Google perinatal hospice video. That will be the quickest way for you to be able to refer back to the English version of it. And then later on in the presentation, I will tell you how to get hold of the translations. So what does this mean for the nursing staff? Where should the care be given? I've presented this at a couple of different couple of different conferences, and I think that I might have caused a couple of mother baby nurses to come close to fainting, but every family is a little bit different, and we don't really know how long these babies' lives will be. And for a lot of situations where the babies have a condition that will not allow them to oxygenate themselves once they're born, it's not uncommon for them to live like in the 40 to 50 minute range. That is just so very many times when I have taken care of these babies, that happens a lot. But there's really no way of accurately predicting exactly what's going to happen. I usually say, if you've seen one trisomy 18 baby, you've seen one trisomy 18 baby. They just really exist on such a range that they really have to be born, and we have to meet them to get a sort of a sense of how this is going to unfold. So some babies will die in labor and delivery. And this is, I think labor and delivery is, to a certain degree, uniquely positioned to be able to do this well, in that they already care for the pre-viable babies that are born on labor and delivery. So it's not an entirely foreign concept to them. Some parents might request a baby to go to the NICU. There might be a specific reason why they do that. And I don't think we should discourage that. If that's what the parents would prefer, that the baby go into the NICU and get assessed and protect, even if they live their life in the NICU, if that's what the parents feel most comfortable with, I don't think we should deny them the opportunity to do that. But there also might be situations where maybe there's a healthy twin that goes to the NICU, and by taking the sick baby in, we can have them be together. But I find for the practice we have here, most of the patients end up going to mother baby. And I do have some pictures of some of these families taking care of their babies on mother baby. And I think that it might be helpful and sort of meaningful to see that. Again, this sometimes scares mother baby nurses when they hear this the first time. And they're like, you're one of what? But please stay steady. Our mother baby nurses, most of them have actually been hired in the 15 years or so that we've been doing this care. And to them, that it seems like a relatively normal thing. We have twice had young women who decided to maintain pregnancies once they found the baby was sick. They planned to have the baby here. The babies were born, and they lived long enough that we were preparing to discharge to home hospice care. And sometime in the middle of the preparation for discharge, we found out that the mother was actually homeless. And we, the team came together, and we allowed the mother to stay as a boarder. The infant stayed as a patient. And the mom stayed in a mother baby room with her baby and took care of them for about 2 days during the time the baby lived their lives. And we had all the specialists would just go in the mom's mother baby room. That was her house. And the moms were able to do a really remarkable job. And the babies lived their lives, and the moms took care of them. And they had a really, probably the best experience they could have had anywhere. So when I first meet people who are in this situation, and usually this is about the time they've already decided that they're going to maintain the pregnancy. There's two common questions that I get from them. The first one is they will ask me, will my baby suffer? And that really refers to the nuts and bolts of palliative care. Palliative care really seeks to lessen suffering in any way, but I will also share with them, and this was reinforced by Dr. Elvira Paravicini, who runs the perinatal palliative care program at Columbia Presbyterian in New York City. I've spent some time working, speaking with her, and she says that, similar to my experience, is that babies that are born with life-limiting conditions very often are born in a state of natural shutdown. They are born with their heart rates and the respiratory rates sort of slowing little by little. And the vast majority of them do not need pharmacologic agents to decrease pain, but they also need to be assessed for pain. And so we need to look at this like a team. So we have the labor and delivery nurses delivering, and the NICU staff assessing, and the mother baby nurses caring, so that this will be considered. But I mentioned this on this particular slide because that's the one question that I get. The second question I get is that the mothers will ask me, will my other children be traumatized by this experience? Those are absolutely the first two questions I get, almost without deviation. So are older siblings traumatized when their parents give birth to a baby who lives a short life? I have found that generally the answer is no. And I think that this picture in and of itself is incredibly beautiful. It's, of course, the dad has carried the baby out from the C-section where the other child are waiting to meet her. And I love the son's look on his face. He's just looking at this baby with just awe. And this family just did such a beautiful job. The sister you see in the center, after this experience, she was in high school when this happened. She has since become a neonatal ICU nurse. Her sister's brief life that she got to share in was so powerful to her. Again, I think that these photos are amazing. They really just show the way that the siblings will cherish moments that they have with these babies and do really well. And very often, even if babies are expected to be born with some unusual facial features, if they may have clefts or something, and I find very often families will be concerned, maybe a little bit fearful, and yet when the baby's born and they present their individual selves, their siblings really are not afraid. They're not upset. They're not scared. They really accept the babies for exactly who they are. So very often I find that dads choose to become very active and hands-on in the midst of taking care of these babies, especially if the moms had to have a C-section birth. So often they've been steady with their wives through the whole thing, with their partners. And when the babies are born, they have the opportunity to dive in and to parent, and they are eager to do so. When I gave this talk in South Africa, I stopped and realized that I think that most of the people listening to my talk, I said, you know, these gentlemen in the scrubs are not doctors, don't you? These are all dads. And they were surprised. They were really surprised. So fathers in these situations, even when they were full of trepidation going into this, often they just bloom in the moment and they parent valiantly. I had one mom that I took care of, and I spend a lot of time with these parents way ahead of time, talking to them about everything under the sun, because I really want to get a sense of who they are as individuals and as couples and as families, and what is going to be helpful for them and what is going to really be interventions that we can use for them specifically. And the one mom said to me one day, she says, when this baby's born, I'm done. I'm going to have the dad do all the parenting. And I was a little surprised. I'd never really heard a mom make that particular request. But I said, well, that's a deal that you guys have made. Yeah, we will support that for you. And once the baby was born, the dad did all the parenting throughout the course of the little baby's life. And as a couple, they did fine with that. But I needed to make that a safe place where she knew that she could have that conversation with me, and that there would be no judgment or trying to talk her out of it or convince her to do something she wasn't comfortable with. That's the way that couple wanted to go into it, and that's the way we let them do it. So often photography is so important. You know, when in other end of life situations, you've got adults or kids that may be at end of life, they have a lot of shared experiences already that the whole family's had together, and these babies very often don't. They have to take this little tiny bit of time and make it as good as they possibly can. This case was a set of twins, and the baby that on the left with you can see the cardiac leads on them. That baby's in an isolate in the NICU, and the baby on the right in the pajamas had died quickly after birth. And the dad wanted to take a picture of them together. And this dad was like an expert photographer. He took pictures of stars and stuff. He was really something. So he asked, you know, can I do the pictures? I'm like, heck yeah, if that's what you want to do. And so I put the babies together in the isolette, and that hand that you see is mine, putting the boys together. And that this was really their one chance to meet after they were born. And then they were separated. And I just find that picture is really beautiful. So every family really is different. Again, I spend a lot of time listening to each family talk about what's important for them. There are no cookie cutter people, so there's no cookie cutter problems, and therefore there's no cookie cutter solutions. I try to see every situation as unique and different. And while I try to see them as unique as possible, the families seem to be very soothed and comforted by the knowledge that we've done this with other families. They like to know that this isn't the first time we've walked down this path. I sometimes describe it to the nurses that it's like a deep, dark forest. I sort of picture the forest that Snow White was running through, you know, this deep, dark, scary forest. And yet we have a lantern. We're sort of carrying a lantern in the forest, going with them. I think one of the most frequent errors I see the staff make is that they treat the family like they are fragile porcelain dolls who will break if we ask them a hard question or a frank question. And in interacting with a lot of these families, I have come to see that I really believe that deep in their minds, people know what they need. And when I ask them a practical question, they will very often, very calmly give me a very considered, rational answer. So I encourage the staff not to sort of treat them like they're fragile or they're going to break. If we need to find out what the next step is, just a very honest and frank discussion really gets us there. So once we've had a chance to really make some planning, once we feel safe, I like to get to the point where I will ask them, if you had 1 hour with your child, what would you want that to be? What do you want included in that hour that would be helpful for you as a family, being the unique people that you are? Recently, with some COVID restrictions, we had one family that the dad was the single visitor who was allowed to be with them. And they really wanted the grandmas and some of the other family members to see the little girl while she was still alive. So we made a plan that the dad, this is before it got really cold, this a couple months ago. So the dad carried her outside to a courtyard with the flowers and the butterflies and the sun and the fresh air. And her family was out there waiting, and they got a chance to see her. We had to keep them at a little bit of a distance, of course, but that ended up being really meaningful for all the family members that got a chance to be with that. So it brings up the fact that palliative care deliveries, a lot of times they break a lot of hospital rules. The rules in the hospital were made for good reasons. They were made for babies that needed vitamin K and to stay inside the hospital. When we do palliative care deliveries and we have a baby who has a short life, I need to work with the administrators to make sure that if we're going to do something that's against the normal course of action, that we discuss it with them ahead of time and understand what the terms are going to be, what the boundaries and limitations that I have to work with. We're pretty good here at, I feel very strongly that anything that is legal, I try to be very keen on knowing exactly where our boundaries are. If it's legal for a family to be able to, you know, we have some families that want to transport babies after they're born, have burials on private land, all those different kinds of things. We make sure that we help them follow the state limitations, restrictions, and guidelines, but do things that are going to be helpful for them. So where do I find out about different families? If I start working with them during the pregnancy, I get specific referrals from obstetricians and midwives. I work very closely with our maternal fetal medicine doctors. I have recently got like 4 referrals to talk to different families, and very often I'm asked to explain the palliative care option, and sometimes parents are like, thank you for explaining that, but no, that's not for us. And I feel like it's successful to be able to give people options even when they decide that they're going to do something else, because it showed that we were able to give them a range and they could pick for themselves what worked. I'm listed on internet databases, and sometimes moms will find me first, and if they decide they want to deliver here, they have to, of course, get an obstetrician and have a neonatology consult. But sometimes they find me first, and then we pull the other members of the team in. We've also been doing this for 15 years, and now we're to the point where people who've had care from us in the past will refer people, their friends might call them and say, I've just got a diagnosis and I don't know what to do. In our system, of course, though, they have to have a local obstetrician and be accepted into the program by the director of our neonatal ICU, because technically the babies we care for here are admitted under NICU care. Maybe my newsfeed on social media is not exactly typical, but on my Facebook feed, I'm always getting stories about, mom carries baby to term to donate organs. And when I see that, I really kind of, it makes me uncomfortable, because I feel like maybe a potentially inaccurate picture is being drawn. I want to cover this topic with you very briefly from my point of view. If anybody it knows more than I do after the presentation or has something to add, I'd welcome it. But because I see a lot of misinformation, I'd like to run through this. When we talk about organ and tissue donation, tissue is really the pivotal word here, because in order for an actual organ donation to happen, the patient needs to be intubated, ventilated, and have brain death criteria established, which really is not typical for this patient population. I did a specific case about a family who chose to do a tissue donation, and it's on YouTube, and it's called Flash and His Gift. If you guys are interested at all in the organ and tissue side of this, I encourage you to take a picture of this screen and get the name of this YouTube video. It's actually in English and Spanish, and it's used by the organ procurement organizations to do staff education. So it's kind of interesting, but I'm not going to take the time to review it in this presentation. But for us, going back though to intubation and ventilation, which is necessary in order to do an organ donation, is generally not part of palliative care. Palliative care really aims to make the best life for the baby and the family, which means keeping them together. So that's really generally not part of palliative care. So this family asked us to coordinate a tissue donation. So in doing that, once we knew she was going to imminently deliver, we had the organ procurement organization committed to having a 24-hour wait time. They had a team here to retrieve tissues after natural death of the baby. So he lived for 16 hours and he hung out with his family in the room, mostly with his mom holding him. And upon natural death, his dad rolled his bassinet to the OR where they retrieved tissues for research for entities who had requested them. And here again, we had weeks and weeks to plan this. So the organ procurement organization went out into the research community and said, what kind of tissues do you guys need that, if we were able to get them, would be helpful for your research? And they compared notes with them. And these are the tissues that we were able to get. And I want to go back to this picture. So I talked about how intubation ventilation is generally not part of palliative care. So palliative care has different domains of care, and there's a number of them, but of them, there's a physical aspect of care. There's a physical domain. There's a psychological domain of care. There's a social aspect of care, and there is care for the imminently dying. When you look at this baby being held by his mother, this photo shows care that is really within those domains. The baby's physical needs are being met, the baby's psychological needs are being met, the baby's social needs are being met. And this is really appropriate care of the imminently dying baby. So I know that way back in the olden days, we used to whisk them away, and babies didn't live their lives with their families. But for the families who choose to do this, this is really this is sort of the way that a lot of palliative care can be done. So often separating them is just really not the goal. Let me go back to where we were. But ethics reminds us that we should never treat someone only as a means to an end. That people need to be treated as an end in and of themselves. And so when we talk about the idea of doing tissue donation, even though these babies' lives are really short, it's important that they are never treated as an entity that is simply there to give extra parts. We need to honor them as individual people, and a donor can be a positive side benefit of their presence, but we need to never lose focus on who the patient is, who the family is, and what the specific goals of care are. So if you are working in a hospital and your employer considers starting an actual perinatal palliative care program, is just more than they're really willing to consider, what might you be able to offer? And remember that almost every palliative care program I've ever heard of, it started with a single person who is a champion with this vision, who really thought, we have all the pieces to put together. We just need a way of doing that. And very often it's a nurse coordinator. Most, they did, Dr. Cote Arsenault, who's a researcher in this area, did a specific research project to find out what the roles of the tasks involved in coordinating perinatal palliative care. And very often it was a part-time nurse with L&D or NICU experience who got towards the end of their career and had a lot of skills that they could apply to this. So if you are potentially a champion with a vision, you might be the person who's well positioned to do this. But if you don't really want to offer something really complex, consider offering a simple pre-delivery meeting for families to meet with the mom or parents. See if they have any special requests. Maybe they just want a larger room to be able to hold their family once COVID is over. Does a hospital have a camera? Could they bring a photographer? Does the mom want the baby to stay with her, go to the nursery? Are pediatricians willing to work with her on these things? So, and then talk to your peds staff. You talk to your peds, and if you have a NICU, the NICU physicians are probably pretty well versed in palliative care. But if you have peds physicians that are in your hospital, maybe they can look into getting some continuing education in palliative care that will help them in their comfort level. So in sort of wrapping it up with some of the important components of care, explain their options and give them time to think about what they want to do. I have a parenting plan. It's like a fill in the blanks, and I send it home with them so they can talk about it in privacy and discuss what options are, and then they come back and we can talk about it more. We make consultations possible during the pregnancy. They can talk to neonatology, lactation support, home hospice services, and they can have all these discussions before the baby's even born. Sometimes when perinatal hospice, which we're now calling perinatal palliative care, was sort of first introduced as a concept, people really mistook it for being a place. Like people are going to go to the perinatal hospice to give, and of course it's not a place. Palliative care is really a philosophy, and it is offered in the same, it's often offered in the same setting as aggressive care, but it's geared specifically for babies for whom aggressive therapies are not going to be beneficial. Resources to inform you as you look into perhaps providing this model of care. Perinatal hospice and palliative care is a website. It's perinatalhospice.org. But if you Google anything like that, it's going to be the first thing that comes up. It was actually started by a parent advocate about 16 years ago, but it's incredibly sophisticated, and the perinatal palliative care practitioners throughout the world actually use this as their storing house of information. They have a section for families and they have a section for professionals, and the editor of the website actually keeps an exhaustive list of professional journal articles about it. So it's almost the first, it's one-stop shopping for information on perinatal palliative care. So definitely, if you're at all interested, I would encourage you to go there. This book is printed by Johns Hopkins Press, and I say that to hopefully make people feel safe that it's not something that's filled with agenda. It's a book for parents who are considering perinatal palliative care for their baby. And most of it, probably 2/3 of the text in the book, are all quotes from parents that have, and it's parents from all over the world, not just the US, but it's a really excellent source for parents. Oh, I should have said, also perinatalhospice.org is where all the links are for the translated versions of the perinatal hospice video. So if you need to get it in Ukrainian, that's where it is. This book is very new. It just came out in late 2020. Brian Carter is a neonatologist ethicist at Children's Mercy Hospital in Kansas City, and he is he heads one of the only pediatric ethics programs in the world, and pediatricians all over the country and all over the world actually go and study through their program to specialize in pediatric ethics. So Dr. Carter, being one of the editors of this book, was a really helpful thing. Rana Limbo and Charlotte Will are both nurse researchers, and they and the people who contributed to this book, it's exhaustive. So it's really a wonderful resource if you're considering offering this sort of care. But it's pretty sophisticated too. It's physicians would find a lot of help in it. But for anybody considering the possibility of starting a program in their hospital, Resolve Through Sharing, who actually started the they were pivotal in starting perinatal bereavement nurse education. They're kind of the gold standard. And they developed a toolkit, which just has a whole lot of helpful things in here, including some of the articles that involve metrics and measuring effectiveness of these programs. This is really not expensive. It's $40. So I definitely encourage that as a resource. And lastly, professional networking for nurses, physicians, case managers, social workers, and chaplains who are interested in specializing or gaining skills in the area of perinatal bereavement and palliative care. PLIDA is Pregnancy Loss and Infant Death Alliance, and it is a international organization for professionals to network. And we only have a meeting every 2 years, but there's a lot of perinatal palliative care is a really strong focus at these meetings. So Shannon, are we ready to queue up the video?
Actually, we have a number of questions, Tammy.
Okay, let's do
We got
that.
a little bit of time, and so I was about to stop you to say there are a number of questions, but then you answered some of them in your last slides, so I thought I'd let you go.
Sure.
But one from was, do you have any good resources for starting a program at your hospital for loss, grief, infant death? Do you know of any nonprofits or grant funding to create this? And I think you just went through a lot of this in your last slide. But do you know of any funding opportunities that would help with any of this?
No, isn't that a shame?
Yeah.
I have found that like in my hospital, we really didn't end up needing any money because they had already decided to have a person who did perinatal bereavement in general, and then starting a perinatal palliative care program, if you've already got a person doing bereavement, is a very natural progression. I'm of the opinion that every hospital that has a large childbirth service ought to have somebody doing bereavement care, because any place that babies are being born, babies are dying. And And perinatal bereavement care, although every bedside nurse should have some degree of expertise at it, it's its own area of specialty. Unfortunately, the certification for perinatal bereavement care, the CPLC, they're having to sunset it because there's only like 300 in the world, and they don't feel like they have enough of a population to be able to have any real rigorous testing. So they're going to, after this year, they're not going to be allowing anybody else to take the test. But no, that's been an ongoing need is to find funding, but we don't have any.
Yeah, another question is, where can you find the state guidelines for postmortem baby disposition? I presume it's on the VDH website someplace, maybe.
Yeah, what's interesting is that there aren't as many limitations as one would think. Like I have it written it's in my Rolodex someplace where it is legal to bury babies on private land if there are when there are specific zoning restrictions respected. We worked it out that we actually asked families to double check with the county before they do it, because we can't really be the police of that process.
Okay, so
But
is this a county decision?
yeah, it's usually done by county, and you can talk to the environmental services area of the county and find out what their rules are. It usually has to do with being a certain amount of distance from a water sources and things like that. But it is legal for families to do certain sorts of transport, and especially if it's within the state. If it's within the state, they can, a lot of hospitals will allow families to transport a baby even after they've died. And you can go cross state lines if you get interstate transit permits. But that's part of my job as bereavement coordinator, is to sort of know the ins and outs of all those things. It's a little bit of a trick, but we even keep transport caskets here at the hospital in case a family very quickly needs to decides that they're going to transport, which actually our transport caskets work really well for Muslim families, and because it's consistent with like the traditional like what they're made of.
Interesting.
But
Next question is,
yeah.
does your perinatal palliative program also extend to NICU parents and their babies that, despite care, even
Yes.
possibly months later, that the infant will not survive?
Yeah, I didn't think of them when I was first developing the program. I was really starting with the image of a pregnant mom at home in my mind, but palliative care in the NICU is so incredibly important because giving a trial of care for babies whose prognosis is uncertain has really become a normal part of neonatology. So if you are admitting babies into the NICU, really uncertain of their prognosis, there's going to be babies who enter the NICU who won't survive, and being able to transition over from aggressive care to comfort care and palliative care is something that it was really so needed. But usually when that moment comes, I'm usually sort of standing in the back of the group going, don't say the word withdraw. Don't say withdraw. Sometimes staff get so used to using that phrase of withdraw ventilator, or sometimes they'll say withdraw care, but please don't ever say withdraw care in front of a family, because palliative care is care. It's just different care. And so we talk about transitioning to comfort care.
Okay. And that kind of actually answers the last question. Is your approach to families whose baby been in the NICU for a while and now is at the end of life differ? So it sounds like it does. I mean, there's a little bit with that. And I don't know, Joe, if you wanted to ask your question more directly, or if you had any other things that you wanted to add.
No, but sometimes, I mean, I think you answered that question, but sometimes we have babies who have been with us for 2-3 months, and then they have bad neck and they're not going to make it. How do you approach those families? Is there a different approach to them? That's what I wanted to ask, but I think you sort of.
Yeah, well, remember that they have probably gotten pretty accustomed to the NICU by then. And so they know their way around already. So I'd be willing to bet that most of them have probably would have probably developed a certain preference for themselves. For NICU babies, I find that there's a couple of different ways. Sometimes we will arrange for them to go into a private room. sometimes they will be going into the mom's, if the mom has had a fresh section, sometimes we'll do palliative care in the mom's mother baby room. We had one family, the baby went to children's and was up at children's, and they realized it was the baby that was not going to survive. And the family insisted that the baby would get transferred back here to do palliative care at Mary Washington. And that was a long time ago. And I told the mom later on, I said, do you realize how innovative that was for you to insist on transfer back so that your baby could die in her own hometown? Occasionally I will have a case where the family feels most comfortable being right around that isolette in the middle of the NICU. I know that seems kind of strange. We always think about like removing them to a different place, but I bet the family has a preference. And if we just ask them, you know, where do you want to be? Where do you want this to happen? They will probably give you a really good answer for some specific reason. But I find that if they've been in the NICU for a while, they've probably developed some pretty strong preferences one way or the other. And if we ask them how they want it to be, they will tell us.
You know, they develop a lot of friendships, and the NICU becomes like family.
Yeah.
So it's certainly been my experience. Well, I think with that, we'll draw this session to a close, this part of our meeting to a close. And we'll take a break here and resume at 3:05. And I guess, Shannon, you're going to show this video now. So if folks want to watch the video, they can. If you need to take a break, go take a break. But we will resume promptly at 3:05.
You have the link, Shannon?
Yeah, I'm working on
Okay.
pulling it up. Sorry.
No, that's good. I
Oh,
didn't want anybody waiting for me.
we will include all these links to all these different things that Tammy referred to on the YouTube site. We may even just kind of pull up the different YouTube videos and have them available on the YouTube site.
And I will read the I'll read the chat in case anybody has questions.
Could you hear that, Tammy, or do I need to?
Yeah, I could hear that. Mm-hmm.
Okay, let me share it real quick.
There you go. Okay.
Here are your early warning signs. And I'm not going to spend a lot of energy or
Okay. Thanks for your help, Shannon. Appreciate that.
yeah, no problem. Thank you for presenting.
Yeah. Okay, I'm gonna go. Let's see.
Faith aspects of maternal, perinatal, and infant loss. And for that, we have a number of faith leaders from different parts of the state. So we can perhaps go in and do that. And what we've asked is that each of our faith leaders take a few minutes, no more than 10 or 15 minutes to introduce themselves briefly, and then where they are, what their roles are currently. And then it tells a little bit about their faith expression and how they counsel patients who suffered loss in the context of that. And also we have Allison Delaney, who's a chaplain at VCU, who makes I think a salient point that even if you have no faith, you need spiritual care if you've suffered loss. So I don't know if Father Mario had to step away or if he's available. And if not, we can, up there is Father Mario. Hey, how are you doing? Thank you, Father. So we thought we just, there's no particular preference. This is just the way folks are listed. So we thought we would ask Father Mario Calabresi to go and introduce himself and talk a little bit from the Catholic and Christian perspective. So Father Mario.
Thank you all. Thank you all for having me. Thank you, Doctor. And it's been great to be with you this afternoon. Yeah, I'm Father Mario. I'm a Catholic priest, an assistant priest here at St. Thomas Aquinas Parish in Charlottesville in Central Virginia. And what I do here, my ministry here, I've been here a parish priest for about 6 years. And part of our duties here is we cover the University of Virginia Hospital, not as chaplains, but we're the parish that provides spiritual care and sacramental care for the Catholic patients at UVA. And also our other hospitals here, Martha Jefferson, and plus we have parishioners that have been faced with the trauma of prenatal loss as well. So I've had a good 6 years of experience here with it so far. Basically, as as Catholic Christians, how we approach it. Shannon gave some very excellent questions for me to present off of. In our faith expression, the question of a stillbirth or prenatal loss, the question of does it have a soul? The Catholic Church has never really pinpointed an exact moment where the soul is infused into our body. The Church really has not taken a position on that, but from fertilization onward, we do treat the body and the unborn child as if it certainly did have a soul. The question of what happens to this soul? Well, in my own practice and the church as a whole, we just simply say that we commend it to God's hands. We commend it to God's hands. And when I work with the Catholic families who have suffered loss, that's when they do ask that question. Often it's not the day of when I first meet them in the hospital, but down the road, they may ask that question, and the response simply is we entrust it to God, who is all good. And there are questions also regarding, for example, couples who have suffered a loss, the question of fatalism in their life. Did I do something that, am I being punished by God for this, etc.? Did I do something wrong as a parent? Is there someone to blame? That too, we just simply, I try to redirect it and focus on care for you and just encouraging them not to blame themselves. And just supporting them in every way with the couples that we have here who have also been through losses of this type. We have here in our parish a great network of families who have suffered in this way, and they're very good at reaching out and consoling couples that have just faced this for the first time. How we deal with it in terms of practical support for the family that has suffered a prenatal loss or even an infant death. We do, obviously, ministry of presence. We're there for them, to meet with them, to listen, really to just shut up and hear their experience, let them talk, let them get it off of their chest. And when I first meet with, a couple, often I'm called to the hospital. Father, there's a Catholic patients here, a couple that have just lost a pregnancy, or it's stillborn. There's no heartbeat. They're asking to meet with a priest. There is a rite in our rituals for the blessing of a couple who has just suffered a miscarriage. And several times the couple has invited me to say a blessing over the remains, which we're happy to do. And, we just offer any type of support. If they're local, if they are a local couple, we do offer a burial. Cremation here is obviously preferred. At times a DNC is needed beforehand, but the funeral homes in the area have been very, 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 very accommodating and supportive of these couples that have suffered the loss. And the funeral homes are very good. We have a columbarium here at our parish, which we offer to all the couples that have suffered in this way, suffered a loss of their unborn child. And above and beyond that, just basic pastoral counseling and allowing them, again, to speak, share their experience, and just connecting them with other couples in the area who are willing to walk with them through this horrible time. So I'm hoping that gives a brief snapshot of the things that I do and gives you an insight as to the Catholic perspective in these different cases and the pastoral support that we give.
Thank you, Father Mario. I had one real brief question. Just I'll take the speaker's, the organizer's prerogative. What about baptism for these babies? Is that just something that can't be done since the baby's already passed?
That's a good question. The sacrament of baptism in the Christian tradition and the Catholic practice is for the living. But certainly there are cases, that Tammy has been talking about earlier, where it's the child has been born and it's a foregone conclusion that he or she is not going to live much longer. only maybe an hour or so. In that case, I go over, or the non-denominational chaplain staff of the hospital performs an emergency baptism. But in the event of a stillborn, prenatal death, at that point, we just again commend it to God's hands. The child has already passed. You know, I do offer to bless the remains and certainly care for them with the dignity that they deserve as human beings. You know, as Tammy said, we honor them as individual people, and we offer a burial and support to the couple. But baptism, unfortunately, once the child is passed, is not an option, but there are other things that can help the family.
Okay, thank you. Next on our panel is Rabbi Hal Shevitz. Hopefully I pronounced your name correctly, Rabbi.
You did.
Thank you. So please introduce yourself and kind of tell us a little bit about, from the Jewish perspective, the topics we've been discussing.
Sure. My name is Rabbi Hal Shevitz, as I was introduced. I'm the rabbi of a congregation, or Atid, that's in the far West End, and a rabbi of a synagogue of about 140 family units. That's how we count membership in synagogue life. And thank you for having me on this panel and for allowing me to bring the Jewish perspective. Just as far as the Jewish legal perspective goes, because there's the legal and the pastoral, and so the Jewish legal perspective goes back 2,000 years. More than that, actually, and these issues derive from actually the Bible, the Torah, the Book of Exodus, which bases itself on, which derives from a verse in Exodus chapter 21, verse 22 and 23, and the verse says, "When men come to blows and strike a pregnant woman so that her children come forth, but a tragedy does not occur, the guilty party is to be fined. But if a tragedy should occur, you are to take life for life." And so this, issues with perinatal issues really derive in the Jewish tradition, and Jewish jurisprudence really derive from this biblical verse. And even 2,000 years ago in the Mishnah, the first codification of Jewish law by the ancient rabbis, there's a tradition that teaches that in the biblical verse, the word tragedy concerns the woman and fine concerns the fetus. And so the sages, the classical rabbinic sages, understood that the Torah did not consider a fetus to be a human life possessed of infinite value. And so this leads into all sorts of Jewish legal decisions regarding abortion, and obviously stillbirth, as this conversation is. We don't have to go into the particulars there, but there is a less than human status of the fetus itself, and the Mishnah, this ancient, this 2,000-year-old codification of Jewish law, says that or determines life to begin when the majority of the fetus has emerged. So what does that even mean, the majority of the fetus? And they go back and forth. Is it the majority of the body? Is it just the head? There are different opinions on this. And these get into all sorts of practical issues. When it comes to stillbirths specifically, it is the case that this that in the unfortunate case of a stillbirth, it is not considered a full human being, a full person. When does personhood attach? That's a very complicated question. But Jewish tradition, or traditional Jewish practice, has the requirement of 30 days of life to necessitate or to warrant the full mourning procedures of Jewish tradition. And so even if those 30 days are not reached, there are some modifications that can be reached. And what's interesting about the 30-day requirement of life to warrant traditional mourning practices, this was decided in pre-modern times when people lived in small communities and when infant mortality was very, very high. And so this decision was intended to be a compassionate gesture that would relieve individuals and the community from what would have been a continuous cycle of Jewish mourning practices. Because infant mortality, if you had children dying all the time, this would just have a terrible pall on the community if they were experiencing these a small community experiencing these mortalities. However, I think this is where, in modern times, especially with the technologies that we have in modern medicine that we have and the care that you provide, it's important to, and this is where the pastoral work comes in, right? It's important to affirm, this tragedy, and offer full mourning rituals so that the family can experience the observances that would be most comforting to them. While mourning the life of that exists for only a few hours or days or a week or whatever, it's certainly different from mourning a life lived over a long period of many years. But the sense of loss and grief deserves that, I think, that respect and that response from the Jewish community and from the practices of tradition. One of the things that, it's going to sound very strange to say this, but I think Jewish tradition does death really well, meaning that our mourning rituals offer comfort and consolation while providing several periods of tradition, transition from acute mourning to lifelong memorial. And it's really, it brings together community, family, and friends to support the family of mourning. And these are well-known traditions within the Jewish community. And as an example, someone who is completely secular in all of their life practices usually wants the most traditional practice for the death of a loved one, because those mourning rituals mean something, and those mourning rituals are powerful and bring communities together. And especially someone who's mourning the death of an infant or a newborn, will find comfort in these things, and to allow for that, and to be a little more liberal in our allowance of those practices, I think goes a long way to providing the comfort and the consolation that somebody experiencing this tragedy needs.
Well, thank you very much. Iman Amar Amonet, I'm sorry if I pronounced that badly. Iman, please, if you want to unmute yourself and introduce yourself and talk about it from the Muslim perspective. Oh, you're still muted, Iman. Iman, you're still muted. Can you wait, please? There you are.
All right. Assalamu alaikum wa rahmatullah. Peace and the grace of God be upon all of you. My name is Amar Amunet. I'm the Imam or religious leader at the Islamic Center of Virginia, located here in south side of Richmond, Virginia, and serving this basic area of central area of the state. Thank you for inviting me. It's been very interesting, and I've enjoyed several of the presentations this afternoon. So thank you for including me in this conference. Islam, of course, comes from an Arabic word. It means to enter into a peace treaty or a covenant or relationship of peace. a Muslim is the person, a man or woman, who is entering into this covenant of peace with God and with their fellow human beings. Islam is an ancient form of what we would call Abrahamic monotheism, of the worship of one universal God. God is every kind of thing that you can imagine that is positive, what we would call divine attributes, everything that is positive, but is transcendent, that is above and beyond our perception. So we don't make anthropomorphic symbols, human-like symbols of God, but we try to understand God as being infinite, but infinitely good in every way. Our life on earth as human beings is a divine gift and revelation of God. And through engaging in this world with nature, living a life of positive good in human communities, among in harmony with nature, we learn and develop as positive, moral servants of God. Every human life is a divine gift and revelation of God. Every human being, male and female, originates in one universal soul created by God Almighty. The Quran talks specifically about the development, embryonic development, human being as one of the great miraculous with the womb from the stages of development before birth, as well as the stages of development of the human being after birth that I think we're more familiar with. And so interesting parts of that development would be, of course, the first 40 days and the visitation of angels or divine servants of God, the breathing of the spirit within the embryo, and then the 120-day period when the heart is beating and the development, as Rabbi Shevitz was out to us, that relates to what can and cannot be done at that statement. For example, to save a mother's life, or because of other reasons, there may be a termination of pregnancy, which is allowed in many different cases. And in general, in Islamic belief, is a matter between physicians and patients. But the sanctity of life, human life, is something that we believe in very much, but there are stages of development before someone is a fully developed, absolute human being with those exact same rights. However, from the beginning of the development of the embryo, if a baby or a child, or if there's a termination of the pregnancy, or as you call abortion or stillbirth, then there are Islamic rights that are required, as well as optional rights that would take place at that time. The child is always, at any stage, part of a family. The family and the ability of human beings to procreate, to marry, and to have children is one of the central building blocks of civilization in the Islamic point of view. And so it's a duty of the entire society to care for mothers, parents, and children, as well as, of course, the development of the embryo and care for the prenatal developed embryo. And so it's very important that we don't think that, for example, some human lives are more valuable and important than others. For example, there's a tendency to think that people who are less financially well off, or who are single parents, or in other kinds of bad situations, that somehow their right or need to have a child is less important, and it should not be valued in the society. But as our future, as a world, future of humanity and our country and nation, it is, of course, in our children. And when there's a mother in need or a child in need, it is all of our duty to care for that family and ensure the best possible future that we can provide for every member of our community. As Muslims, we provide a lot of spiritual support for the family. I personally have to deal with the situation of loss of child before the child is born or shortly after. In fact, this weekend I had to bury a child who was carried in the womb for 5 months, and that child's poor mother has already had 4 losses, unfortunately. And we have a special little section of our graveyard for babies. You know, I say our little angels, they're little, very small little graves. I think somebody pointed out that they're little caskets that are provided, little small boxes, and we do normally bury children in those boxes. And so at any stage when their identifiable remains, we, of course, prefer to treat that as a human being. We don't treat it simply as tissue, and we prefer to bury that. But we don't, because it hasn't lived and it isn't, you know, it was not a viable child, we don't do the normal washing and anointing and shrouding that we would do, but we wrap it in white cloth and provide it burial and prayers. If there's a situation where family are about to deliver a child's stillbirth, or maybe a child is born alive but doesn't have any hope of survival, we can support family in doing prayers and recitations of the Quran that are chanted, which normally we do at the time of death. Muslims find a lot of comfort in faith that they will be together with their family members in paradise, in heaven. And we believe the family is something that extends beyond our life in some way, in some mysterious way. We are together with our loved ones. And so the child at any stage younger than adulthood is an innocent human being, not responsible for doing evil. And so they are pure and innocent. They are not in need of course, they would not be condemned to hell or something like that. They're not in need of forgiveness because they're not sinful. And so we talk to the parents and instruct them that the child will be in heaven, and it is an intercessor on behalf of its parents. So we're sending an emissary to heaven to prepare our place in heaven, and the child is in the care of Abraham and prays for its parents and intercedes with God for forgiveness and grace for its parents. And we hope that provides them some comfort, and that as any suffering in this world, we endure patiently what is negative as well as those things which we enjoy and find pleasant. And we show our faith by trying to be patient and not losing hope, but that we will have a divine reward and atonement because of our patience during that suffering, and that any grief that you feel is absolutely natural and positive, and is not in any way wrong or sinful to feel grief. Especially mothers feel a huge attachment, even at very early stages of their pregnancy, in my experience. And they have every right to keep that feeling and discuss it or not discuss it as long as possible. But we try to give them that feeling that that child will be with them, and it is not an absolute loss. But just like other kind of suffering, we all lose family members in our life, and all of us will lose our own life at some stage. And it's part of our human natural life cycle. Just as the development in the womb, we go through a life cycle from birth and maturity and death. And we accept that. And that's part of our surrender and communion with God, and our covenant with God is to accept those things and to live in faith with the natural reality of the world around us. I hope that's a little bit helpful. And I'm happy to answer any questions that anyone has. Thank you so much for inviting me.
Yeah, thank you, Iman. We really appreciate that. I think to kind of maybe tie some of this together, we have Allison Delaney, who is a hospital chaplain at VCU. And perhaps she can talk about how she helps manage families or help families with these issues from a more broader perspective as opposed to a specific faith expression. So Allison, you want to tell us a little bit about yourself and how you help try to assist all these different families coming from different places?
Thank you so much, Dr. Dudley. And thank you, Dr. Corey, for inviting me to be on this panel. I was overwhelmed, I have to say, at the beginning of this conference, just by the enormity of, infant mortality and maternal mortality and statistics, the health disparity that we face as a nation and as a community. But I find hope in this conversation that, in the 200, I think, some participants that I saw at one point on our Zoom, we are bridging together a very important and delicate conversation, which is, how do we provide respectful care? So just to introduce myself, I thought I'd say a little bit about who I am, my role here, and then also talk about a little bit about language to help our discussion. And then in talking with Shannon, I appreciate practical things when I walk away from a conference. So there's one specific tool that I thought maybe could be helpful to our audience in terms of bridging the gap between how do we ask the question about spiritual and religious needs so that we can partner with our community faith leaders like the ones here on the panel. So first, my name is Allison Delaney. I'm a full-time faculty chaplain here, working at VCU, working primarily in women's health and pediatrics. So my area of expertise, mostly where I float, is the neonatal intensive care unit, but also in the labor and delivery area and the healthy women baby unit. Really, I'm in the family planning clinic. So I'll also share that, many times I'm called to support families who have chosen interruption of pregnancy abortion, and the immense spiritual pain and support that is needed in those environments is also where I feel called to be. So I feel like, yes, I stand on a threshold, right, between the intersection of the healthcare system and healthcare delivery and all that involves. And then also, what are the resources, the spiritual and religious resources that help people that they turn to when they need to navigate probably the hardest moments of their lives? And then how do we help bring that all together, right? So it's, for me, a privilege. I think it is a privilege when we find ourselves in these moments, sitting at the bedside, standing in the mystery. We don't always know what's going to happen. We can use our best medical prognostication, and then we have traditions to hold us up, but we stand in the mystery truly together. And so what I hear in in these three faith leaders that have just shared is some commonalities. Like, we're all human beings here. We all have this belief that every life is sacred and has dignity. That we are, I'm going to use your words, Tammy, because I really liked it, that we practice communal bravery. I really like that. Because it's really like from the gut, like, how are we willing to stand there and be compassionate when it's really hard and we might have a conflicting experience in our own lives that maybe we don't agree with where that patient and family is choosing at the moment. Maybe we think there's a better way, but then also practicing that cultural humility, not competence, but humility, that, I'm going to be an imperfect human being right here, and I'm going to walk with you, and you're not going to be alone on this journey. So I feel like that's a great privilege that we all have, and that I get to practice as a chaplain, and which is why I love what I do. So let me, for a brief moment, try to share. Can you see that PowerPoint that I just, okay.
Yep.
Great, thank you.
Yeah.
Thanks. So one of the things in having this conversation I thought could be helpful is talking about, well, I like this quote, so I just want to share this quote from Dr. Rachel Naomi Remen. So she is she's written a book, Kitchen Table Wisdom, I think another book, Grandfather's Blessings. She has this beautiful way of capturing stories and deeper meaning as she does patient care. She's an internal medicine doctor. So she says here, listening is the oldest and perhaps the most powerful tool of healing. It is often through the quality of our listening and not the wisdom of our words that we are able to affect the most profound changes in the people around us. When we listen, we offer with our attention an opportunity for wholeness. And so I just don't want us to underestimate the power of taking the time to listen. And that's challenging in this healthcare, so many demands. During COVID, it's even more important. Like, we're isolated, we're hungry to be heard, and for that just human presence. So I just want to highlight the power that we all have when we take the time to listen, non-judgmentally, and especially in these precious moments. There we go. So quickly, definition. So I've done a lot of work in trying to explain what I do as a chaplain. And so, it's different in, say, the military and BA system, where chaplains are denominationally based. So healthcare chaplains are trained differently. So while I have my own spiritual practices and tradition, my main undergirding definition is that all human beings have a need to have meaning, especially during death and loss, seek meaning. So how do we talk about spirituality and religion? So spirituality, I like this definition by Dr. Christina Pahalski. She is the founder of the George Washington Institute for Spirituality and Health, and a leader in interdisciplinary conversations like we're having today. So spirituality is the aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to themselves, to others, to nature, and to the significant or sacred. So I listen for the communities of support. How are people coping? The language they use, and that's my guide, because often I find people will tell me, once we make them feel safe, they'll tell us what we need to know. Sometimes just in having that safe space of listening, they learn things about themselves that they weren't able to say without an audience. So spirituality is fundamental to being human, is how I understand this definition. And religion is this search for significance that occurs within the context of established institutions and traditions that are designed to facilitate spirituality. So there are many that are religious that find that connectedness to themselves and to others and history to guide them through perinatal loss, through this, I think as the rabbi said, you know, they, even if they're not practicing Jews, but in that moment of death, go back to the ritual. That's very powerful. So that's how I think these are helpful definitions so that we don't, so that we're on the same page when we speak about this. The practical tool that I thought I'd just throw out there, and I don't need to spend too much time on this because I want to leave time for our Q&A, but I guess you can't raise your hands, but I'm wondering how many people out there have ever heard of the FICA tool. So it's from, again, Dr. Christina Pahalski, who defined spirituality. Actually, it wasn't just her, it was a whole conference of people that defined that. But this screening tool is specifically for providers, so medical providers at the bedside. And it's an art, right? So this is, again, it's the balance. I'm not using this like a formula, but as a guardrails for how to have this conversation if you're new to it. So a way for a provider maybe at an annual exam, something like that, I have to think about how to incorporate it. Like if you know the patient in the prenatal clinic, that makes sense. In the moment of perinatal loss, we got to be careful about using this, but I'm thinking long-term relationships here. So faith and belief. So importance. So what is important to that person? What is the community they find support in? And then how do we then bring that together with the care? So our values and beliefs definitely come into play in these family meetings. You know, how are people understanding things? Do they need to consult their spiritual leader? What are these values and beliefs doing to what their goals are versus what the team's goals are? So here's some language, and you can adapt it for yourself, but I like that she at least gives a format. So to assess faith and beliefs, do you consider yourself spiritual or religious? Sometimes if I ask that as a chaplain, they're like, oh, I haven't gone to church in a while. And it's almost like this shaming. I'm like, no, there's nothing wrong if you haven't gone to church. I was just asking if it's something important to you so that our team can, follow up. Or how can we make this room more comfortable for you to express your spiritual practices and religious practices. So you could say, is spirituality something important to you? Do you have spiritual beliefs that help you cope? And even if they say no, Dr. Pahalski recommends asking a follow-up. Well, what gives your life meaning? So if they don't have that language, what is it that gives your life meaning? Because that's important to our goals of care. Importance. How does that? What importance does your spirituality have in your life? Has your spirituality influenced how you take care of yourself or your health? So this would be about, an adult mom. And how does that impact your decision making? Community. So are you part of a spiritual community? Is this a support to you, and how? Is there a group of people you really love who are important to you? While I'm thinking of it, I just want to acknowledge when encountering death, I would say adult or perinatal, it is a time of questionings for many of the families that I see. And so I feel very privileged if they let me in, that sometimes they start questioning their faith, and not maybe permanently, but just for a moment, like, why did this happen to me? And am I being punished, like Father Mario said? But for a time, I think some families have shared with me they needed to take, cocoon, that's a bereavement term, to survive, to grieve before they return to worship with their communities. And so just acknowledging that that's okay and normal, and then how to support them even in that questioning time. And how can, our faith communities be aware of that might be a time to reach out more sensitively. Addressing and care. So again, this is where the rubber hits the road. So as a provider, how would you like me, your healthcare provider, to address these issues in your healthcare? So I don't know how comfortable those of you in the audience feel about that question, but I think it shows a lot of care. So there's been research done where, some physicians were like, this isn't within my scope of practice. Like, I wasn't trained to ask about this. But when you ask the patients on the other side, they've shown a lot of evidence in research that they appreciate being asked the question. And they can say, no, I don't, thanks for asking, but nothing. But it shows care is usually the way it's interpreted. And this is just a plug for chaplains. I think a lot of the nurses who know me on L&D and NICU and other parts of the hospital, they've learned to say, hey, we have this person that's part of our psychosocial team. Her name's Allison. I think she'd be a good person for you to meet. And leave it at that, because the word chaplain comes with some heaviness sometimes, like, oh, she's going to come and try to proselytize to me. And right now I'm like, I'm in the middle of labor. I'm stressed out. There's presumptions that sometimes negative ones that come. And I had no need to be in the room, but it's in assessing religion and spirituality, sometimes the language and the timing, it just really needs to be considered carefully. So the last quote I'll say, and then I'll be quiet and let the questions come in, is a quote from Maya Angelou, which she so beautifully states, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And for me, that summarizes, I think, what we're trying to do today in this conference. And so I'm excited for whatever questions come our way. Thank you very much.
Oh, thank you, Allison. That was great. I've never heard of the FICO tool, and so I actually wrote it down here. We'll see if we can make some questions. Shannon, did you want to, I have several questions and I don't want to monopolize things. So if other people have questions, please put them in the chat box, or we can let you raise your hand here soon. It looks like Tammy has one right off the bat too. But Shannon, you want to kind of lead the question and answer phase?
Yeah, sure. First of all, thank you to everybody. Very informative, and I'm anxious to see kind of some of the results as a follow-up afterwards. So we might be in touch to have further discussion in a more kind of a monthly format. So this one is to you, Rabbi. Can you please walk us through some of the traditional Jewish mourning rituals that would pertain to an infant death?
Sure. And the mourning rituals, which I'm about to describe, aren't specifically limited to infant death, but just are just Jewish mourning rituals in general. As far as and as I mentioned before, tradition says that within 30 days they do not receive these. But as I said before, this is where the pastoral aspect comes in, and the rabbi in working with the mourner says, this is probably going to be the best thing to do. So, even though tradition says not to, we're going to go anyway. First off, in Jewish tradition, it's a custom to bury as quickly as possible. In the most traditional communities where they are close knit and everybody lives in the same area, sometimes they'll bury the deceased later that day or the next morning. And this is because of the belief that our human being is created in the image of God. We are the image of God, and an inanimated body is a diminishment of the image of God in the world. And so we want to bury that body as quickly as possible. Before burial, a body is ritually washed by what's called a Hever Kadisha, a burial society. They ritually wash and shroud in a white garment, a plain white garment, which is what they are eventually buried in. The deceased is buried in a plain wooden box. The idea is that we are all equal in death, and there is no there's no distinction between wealthy or poor when we go to our final resting place. And so the casket which carries us, which holds us, should be as simple as possible in all aspects. As far as there's all sorts of prayers of mourning, but what's essential to know is that once the deceased is buried, the relatives, the immediate relatives, become mourners, and there is as I was describing before, stages, transitional periods of mourning. So the first, so immediately upon burial, begins what's called Shiva, and Shiva is in Hebrew the number 7. It's 7 days of the intense mourning period, when basically you're not supposed to leave your home. You wear either torn clothes or a torn ribbon to show how your soul is torn at this time. People are supposed to come to you and pay visits to your home, and comfort you and comfort the mourner. And after that period of Shiva is over, there's the period of Shloshim, which means 30, and it's a transition. So you leave your home, but you don't, and you take care of your basic needs, and you go to work, but you don't go to entertainment. You don't do fun things outside the home. After the 30 days, you enter the year period, which is Jahrzeit, which is the old German word for year. And from that point on, you mark the year anniversary of the death of a loved one. And part of that, a very essential piece of that mourning, is to recite the prayer, which is not really a prayer, it's more of a recitation. It's called Kaddish. And that Kaddish is recited for the first time at the grave, and it's recited all throughout Shiva, and on the Jahrzeit, on the anniversary of the deceased, recited by the mourners. And Kaddish is actually a doxology. It is a list of God's attributes, and affirming God's greatness and God's holiness. Has nothing to do with death, but one of the reasons that we recite Kaddish is that it's a familiar prayer. We know it. It triggers that peaceful sense of comfort that we get because of its associations with mourning. And really, the idea of praising God in this way goes back to what I said earlier, in that with the death of a human being, God's image has been diminished, and so what we do is we counteract that by praising God. And we counteract the diminishment of God's image by saying, and the first few words are, magnified and sanctified be the great name of God. Had to think about that in English because I say it in the traditional Aramaic instead of English most of the time. So those are in a nutshell, traditional Jewish mourning rituals. Again, burial is done quickly, and sometimes this is shocking, and sometimes this provides comfort. It's like you bury it and that's it. Like the person's in the ground and that's it. But on the other hand, it begins the process of mourning quicker. Right? They're not the person's body is not just there to be to be mourned over and to be bewailed upon, and so the transition and the movement from acute mourning to comfort and to life without begins with that process.
Great, thank you. Tammy, if you want to unmute and ask your question.
I think I had more of a comment than a question, although I appreciate that Rabbi's description of that. I think that the Jewish mourning rituals are so beautiful. I'm always taken by them when I hear about it. I know that you guys were talking about different ways of consoling people, and I noticed when it comes to consoling families specifically, in terms of something that I have found very helpful to help people cope and heal, is is to work with them from the moment people get to the hospital till ongoingly on interacting with them, is to recognize positive moments of parenting, and in all of what they do to build esteem in their, and how I have watched them parent, and as they're taking care of their baby, say, oh, look at how good you're doing that. And building parental esteem, I think is actually probably the single most strongest indicator I've ever seen of kind of healing and coping happening with people. When I was listening to the father speak, to the Catholic priest speak, I'm reminded that when I take care of families for whom baptism is part of their tradition, if we can't get the chaplain or the priest to the bedside fast enough before it looks like the baby will die, I will coach the dad through baptizing the baby, or the grandmother, because I will describe, this is a gift you can give this child. You know, if it's people for whom baptism is a tradition, I'm not trying to talk them into it in the moment, but if it's part of their tradition, I encourage them to see this as a gift, that if the family can give it to them, it's really so beautiful and nobody can ever take that away. Because the dad that I'm taking care of, it might be 25, but someday he's going to be 35, and someday he's going to be 45, and someday he's going to be 55. And I want him to be able to look back on that. And if somebody said, tell me about that was when you lost your baby, I want him to be able to say something like, I baptized my child. You know, he probably will forget that there was a nurse coaching him to do it. I hope he forgets that there was a nurse coaching him to do it. But if he can remember that he did that. And the last suggestion I'll make, and this is something that nurses can do in their own communities, or that chaplains can do, but I ask for my friends to give me antique handkerchiefs that I keep in my office. And when I go in to meet a new mom who's experiencing perinatal loss, I give her one of these nice handkerchiefs, and I tell her that her tears are not trash. Instead of handing her a piece of Kleenex that she would cry into and throw in the trash, I tell her that her tears are not trash. And then sometimes when she's had that Kleenex for a day, or she's had this for a couple days, when I go to remove the baby from the room to go take them away, knowing that they were never coming back, sometimes I wrap the baby in the handkerchief that the mom cried into, and it's part of her actually physically going with them. So it's more psychological support than spiritual support, but they are kind of all rolled together. And there's the only things I was going to add. So thank you.
So Father Mario, maybe speak to the issue of baptism, because at least for babies that are born alive that are destined to die. And, you know, my understanding is you do not have to be an ordained clergyman to baptize a person.
Yes, I'm glad Tammy brought this up here, because that is an important thing. I mean, in the Catholic tradition, the priests or deacons are the ordinary ministers of baptism. But in an emergency situation, many times I get a call and they will say that, you know, the baby's going to die within the hour. I just say, you don't even need to call me. And I think a lot of the times the chaplains over at UVA, they do it themselves. And I think it's a very good, positive thing to offer it, you know, to the father or one of the parents, because anyone in the Catholic understanding of baptism, any human being, as long as they intend to do what the church does, can function as a minister of baptism in an extraordinary circumstance. So that would include the parents, it would include a nurse, it would include a person of no faith at all, who simply just intends to do what the church does for this family who is in a crisis. You know, I think that is a very good, I think what you mentioned is a very, very good option in lieu of a priest being there, making that an offer as a healing experience actually for the parents. So yes, but that is I hope I clarified, Doctor. Yeah.
If I could throw into that, because we have 150 probably nurses around us, especially NICU nurses. And when I'm responding to a code in the emergency department or the NICU, where you have an isolette that's completely surrounded by doctors and nurses and respiratory therapists, I responded to a death in the a baby code in the emergency department, and everybody was around them, and the priest literally could not get to the baby. Right. And so I told the priest and the parents, you stay here and pray. I will walk over. And I walked over, literally had to squeeze my body in between people with water and I did a Trinitarian baptism, but I say this because nurses may need to be the people that do that because they may be the only person that can get to the bedside. So if you're
Right.
needed, have the priest teach you how exactly what to say. But like in that moment, there was no way that a non-medical person was going to get to that bedside. Sometimes we need to be the person to wiggle their way in.
That's absolutely true. I know many people who were baptized by the nurse, and it's important for them to, if they're willing to function that way. Absolutely. Yes, totally.
Father, is there a resource where people can go to know what to say? I mean, what do they say to baptize? What words do they have to use? Is there anything that they can use?
Yep, you can find it on the internet. The formula is just simply the name. I baptize you in the name of the Father, pour of the water, and of the Son, pour the water, and of the Holy Spirit, pour the water. So just simply say that. Joseph, I baptize you in the name of the Father, and of the Son, and of the Holy Spirit. And after you say each person of the Trinity, Father, Son, Holy Spirit, you pour a little bit of water. And it can be ordinary tap water. It doesn't need to be holy water at all.
Would that be the same for a Protestant birth? Would you know, Father? Because if there's a question, how would a nurse coach a family member to baptize? I mean, this is from the Catholic tradition. I just don't know about other Christian traditions.
As far as I know, Trinitarian baptism, that is how it functions. I know there's a difference in different Christian denominations, Orthodox, Catholics, Protestants, about the need for full immersion. But as far as I know, I think the Orthodox and most other denominations know that an emergency situation, a pouring can be acceptable.
When the family doesn't have a name, if they don't have a name, what I usually say is, precious little one whose name is known only to your Creator, I baptize you in the name of the Father, this, and because I figure if the parents come up with it later, well, the Creator still knew. So that kind of works in the moment.
Right.
And if I could piggyback, so in our NICU and labor and delivery, we also, again, we're talking about, do we have time to prepare or don't we? And sometimes we have a little bit of warning. So we have shells that could also be part of that memory making, Tammy. It's so important.
We do too, yeah.
So shells that the water can be placed in, and then whoever confers the baptism, but that becomes another, when you think about it, for perinatal loss, the difference between that and adult loss is that sometimes the only people who get to meet this child are in the NICU family, and especially with COVID, lack of visitation. So it's this very important thing to have as many memory items as possible. And in terms of other, Dr. Dudley, your question about baptisms from other traditions, this is where the assessment piece is, and just asking that question of families, like, and not guilting them, sometimes in asking the question, you have to be really careful. Like, sometimes we want to be, give something to do in an intense moment. I don't know if you see this, Tammy, or if any of you experience this, but it's like, oh, mom needs to hold, and mom needs to do a baptism. I'm like, well, did she ask for it, or is that kind of whose need is being met to do something in this very sad time of suffering? So just to take breath and be like, okay, is the baptism needed? Is it a blessing, perhaps, or is it, what is the need of the family truly when you talk to them, and then how can we best meet that? So
I try to very gently say, is baptism part of your tradition? Like in a way that's so gentle that if they say, well, no, then it doesn't sound like I was pushing too hard in one direction.
Yeah, and I wasn't saying that you were, but just to be mindful that, the question is, like, for every family, it's different. So even for, 20 different Jewish families, or 20 different Muslim families, or 20 different Catholic families, the way that they understand and need and draw upon their faith in that moment is different. So it just needs nuance.
Well, I would be interested to hear from the rabbi and the imam from their faith expressions in these kind of immediate moments. is there anything that we can expect our patients to either ask for or request that we don't know about? Like if they're, if they have a baby that was born either very preterm, but born alive, or in one of these hospice or palliative care situations where we know the baby's going to die soon, in that immediate moment, what can we do to help our patients? And are there going to be things that they're going to be requesting that we should respond to? So Rabbi, you want to take that?
Sure. So in some cases, they might ask to speak with a rabbi. I mean, and just to have someone a spiritual leader to listen to or speak with. One of the things that is traditional to recite, either the deceased or the dying does this, or someone does this on their behalf, is either it's called the deathbed confessional, and it's a programmed pro forma kind of recitation that kind of atones for a person's sins during life. Obviously, that would not apply in this case, but an essential piece of that is reciting the central statement of faith in Jewish tradition, the Shema, in Hebrew, Shema Yisrael Adonai Eloheinu Adonai Echad, translates to "Hear, O Israel, Adonai is our God, Adonai is one," and that is a statement that all Jews in all cases, almost all cases, will know, and will either want to recite or want it recited presently when someone is actively dying or who has died. So that's something, the Jewish statement of faith that someone might want recited on their behalf, or someone to recite for them, or to be with them as they recite that, to listen as they recite that. So I could certainly imagine that being an important piece of someone's experience as they're in the situation.
Iman, is there anything immediate that we need to be thinking about for our Muslim patients? Need to unmute yourself, sir.
Yeah, thank you. Yes, similar to what the rabbi said, normally, of course, obviously for adults, they want a period of reconciliation with God and pronounce the confession of faith. And family or community elders or imams may be requested to do prayers and recitation for a child, for a stillbirth, while it's still alive or after it has died. But a lot of families would have an elder member who would do that, or they would have their own prayer books they would use, or they may, call us or someone else in the community. And we have, basically, in the Muslim community, we have a committee of volunteers who assist people in death and preparation and burial. And so they're contacted usually right away, before or after the death. But there's not a baptism ritual. And as I said, children are innocent, so they're not suffering because a ritual wasn't performed for them. But it is a great comfort for families to hear the familiar blessings and prayers that take place. And of course, we do that as a service to anybody who requests.
Okay. I do have a follow-on question. Because of what I do as a high-risk obstetrician, I counsel women and families often who've had a stillbirth in a previous pregnancy. Mm-hmm. And one of the things that I will always do when I first meet the patient is, as we go to talk about what happened during that stillbirth, I will always ask, what was your baby's name? Because at least in the Christian tradition, naming is very important, or tends to be. And I know I've had several patients who have thanked me for acknowledging that name and that person, that baby was a member of their family. because a lot of people are very uncomfortable talking about that. And so in the Muslim tradition, is there naming of a stillbirth? I mean, do they name the baby after the stillbirth?
Yeah, traditionally, children were named on the 7th day. And so depending on their background, nowadays, a lot of people have already chosen a name, or they may not just publicly speak the name, but a lot of people now are very happy and want to name the child. And of course, we do memorialize the name of the child, even if it was never born alive. We will do that for the parents. But there are still a lot of traditional cultures where the child's name isn't spoken before the 7th day. And so we let them kind of steer that the way that they're comfortable.
Yeah. And Rabbi, what about in the Jewish tradition?
Yeah, very similar to what the Imam was expressing. Although in traditional circles, it's the 8th day when the circumcision occurs for boys. When it comes to so in most cases, names are picked out ahead of time, and it can help, and it can help with the family speaking about a person, right, and mourning. And so baby boy Smith or baby boy whatever, the baby girl, it just doesn't resonate, doesn't connect. And so people, if they have the name, then it's certainly encouraged to use that name in mourning. I've often seen the case that in a situation like this, people will reveal the name at the burial, where obviously it's it'll be private among the family and between the physician and all that, but they will reveal the name publicly at the burial, and that creates a personhood for the community. But I again, very similar to the Muslim tradition.
And Father Mario, any comment from the Christian tradition about naming? You're muted also, Father Mario. It's the Zoom culture we live in, I'm afraid.
That's it. Right. Yes, there's no requirement that Catholics have in terms of naming at a particular time, but the majority of couples that I've worked with who have suffered a loss, certainly the child was far enough along where they knew the gender, they had a name selected mostly. And so that's very, very helpful, I think. Hearing their name at a funeral service or a small mass with just them and their parents for the child, is having that name there selected really is a source of comfort, knowing that he or she had an identity, that they are our son or our daughter. But for those children who, a name wasn't selected yet, quite often the couples that we work with, the families that we work with, they just simply choose to intern in our Holy Innocents niche in our columbarium. We just simply have one niche of the columbarium that simply is marked Holy Innocents, whether they had a name or not, and we inter them there. So, but yeah. I hope that's
Allison, what's your experience in just as a chaplain with this?
I think I'm trying to remember what I say. So there are families that are very grateful to have other people speak their child's name, just as you shared. And then there are also some in the grief who choose, I think, to distance themselves, or not distance, but to cope by not having a name. And so I try to give a lot of space for quiet to let them speak first, and then I can follow their lead. So I try not to speak too quickly. For some, I try not, again, if I say, what is the name of your child, and they haven't picked one, they're like, oh, I don't know. So sometimes I say it, how do I say it? I think, did you get the point, so early in the pregnancy of wanting to choose a name, and then go from there. So sometimes I just kind of I don't assume that they've chosen a name. But for different families, yes, it's powerful. So if there's a blessing, a baptism, we actually have certificates in our chapel. So our chaplains will, make that part of the memory box for them. And this is if the child lives or dies, if they choose to have that. But always facilitating, is there someone in the community, if COVID visitation allows, to have the community faith leader come in? Because again, that's another person to affirm and witness the existence of this child, if that's what is wanted. So it takes many different forms. Does that sort of answer the question?
I have a strange suggestion for families when it comes to names, that this might be kind of off the wall, but it really helps sometimes. When I'm working with somebody who had a very early loss, very often they may not have known the gender and a name wasn't picked. We have a burial program here, and sometimes I will ask the family if they had a name. And if I hear what you're saying, very much so, if I start to sense this, we didn't really know, we don't have anything picked, I say, that's okay. And I'll say, I have an idea. It helps for a lot of families, but I'm very careful not to push people too much into this, is that if the loss is very early, they didn't know the gender, and picking a name for the parents wasn't a big thing, I asked them if one of the children in their family was more affected by this loss than any others. And a lot of times families will say, yes, my youngest child, they're so upset. I said, think about the possibility of letting that child pick a name for this baby, because you allowing them to pick a name is such a respectful thing, and the child will feel respected by getting to name their sibling. And if the parents are at the point where they really didn't care one way or the other what the baby's name was going to be, by handing that over to the child, I said that child will never forget that they got to name their sibling. I've had a lot of families do that, and they came back later and they were like, the child loved picking the name for that baby. It wouldn't fit in every situation. It's definitely sort of an oddball little thing, and it especially helps for early losses. But I've had that conversation about 100 times, and I've had families say that was really helpful.
Okay, thank you. I had one other question, and I don't know if there are any other questions that people have, but when we were deciding on who to invite to discuss this, we wanted to have someone from each of the kind of major, religious expressions that all come from Abraham, so Christian, Muslim, and Jewish, but knowing that there are within each of those, there are multiple branches. And if we invited someone from each one of these, we would have 4,000 people on the call. And so a lot of these different branches come more from not necessarily religious teaching, but cultural tradition. And so one question I had for each of the faith leaders was, how much of what you talk with patients about comes from religious teaching versus the cultural tradition of the specific branch that you're in that religious expression? So maybe Iman, you could speak to that, because I know there are multiple branches of Islam.
Yeah, of course, obviously, humans are always going to subdivide into every, but so the Islamic community is extremely diverse. People are from Asia, Africa, Europe, Latin America, North America. The largest tradition is what is called the Sunni tradition, which is close to 90% of Muslims, but then there are subdivisions within that. And then of course the Shiite tradition is somewhere around 18%, more or less. The things that I described are pretty much what everyone would be familiar with, but there are particular cultural and generational differences. I still am learning after many decades of doing this. And so it never hurts. And of course, any chaplain with any experience would know, let them kind of express where they're coming from, and they will kind of steer you in the right direction. But so I try to, of course, being part of an extremely diverse community here in Virginia, express basically what is the consensus of the vast majority of people, rather than one particular branch.
Okay, thank you. Rabbi?
Yeah. Similarly, you know, the particulars of Jewish mourning rituals are basically the same all across the board. What you will, the difference in the diversity that you'll see is how observant a particular person or family is within the confines of Jewish practice. And so, you know, there, you know, as I was mentioning, you know, a while back, that because these rituals are well known and bring comfort, even the most secular person, even somebody who does not observe many of the other rituals as far as you know, Jewish dietary laws or keeping keeping a strict observance of Sabbath, will want some of the most traditional of the Jewish mourning practices. And so really what you'll, as I was saying, the difference that you'll see is, you know, in the observance of these things. So for example, to be really specific, where the most traditional Jews will actually tear a garment as opposed to tearing a ribbon and attaching to their clothes. Where the most traditional Jews will observe a period of Shiva for full 7 days, where less traditional will do 1 day or 2 day or max 3 days. And so the diversity really comes into play with the adherence to tradition and how meaningful that the observances are into their daily practices. So, and I would assume that most rabbis would answer give a similar kind of answer.
Thank you. Father Mario, you know, the Christian tradition is the poster child for branching and fracturing. So,
right, we certainly are. I mean, in terms of what I've described and tried to speak to as best I can is certainly the Catholic Church's Latin Rite tradition. The things I mentioned that we offer in terms of pastoral care and ceremonies and things that can help and assist with closure and with some healing on the part of the parents. You know, certainly is offered by other branches of the Catholic Church that are of Byzantine or Oriental, or we may call it Eastern Rite Catholicism. Where I'm speaking of, you know, I'm a member of a Western Rite, Latin Rite, you could say Catholic Church here, parish here. But, you know, how this plays out in an individual family's life, it depends on a lot of things, where the Catholics or the Christians are located, what the cultural setting is, and how much, you know, that society allows a couple to grieve, how much they feel like that they have the liberty to do that. And it just is so very individual. So it's important for, you know, we've already touched on this already, for me or any other Catholic minister or Christian minister, just don't presume that, you know, a couple or a family who suffered a loss like this is going to be in a particular place, where you really just have to meet them where they are and adapt the rite and what you offer to what their needs are at that given moment, if this makes sense. Okay.
thank you. Joe, you have a question?
Yeah, I have a question. So I don't know what your experience is with a family that's multi-faith. So if mom is one faith, dad is another faith, or vice versa, how do you approach that in general? And anybody can answer that question. Do you have a preference, or do you take a step back and let them tell you what they want? How would you approach this?
I mean, my particular experience, obviously that's very, very common. And a lot of times people will let you know what their particular practices are. And so Muslim imams can talk to people who are not Muslim, they can talk to Christian and Jewish people, but of course, try to help in whatever way, but usually they signal to you what their needs are. And it's not uncommon at all that people are Christian, Jewish, Muslim etc. families, and they have their own individual kind of adaptation. And that's the world we live in today. Is a very diverse world. But we're always very happy also to help anyone who needs to contact someone from a tradition. We can help them do that as well.
It's in my experience that if somebody specifically calls a rabbi, they want a Jewish perspective, right? And so, you know, thank God I have not had to deal with your particular issues in an interfaith setting. But when someone calls a rabbi, you know, I'm gonna share Jewish tradition, and I'm going to speak from my tradition, and not that I'm going to preference one way or the other. I mean, I am, but if they call the rabbi, like they want me to bring a specific tradition, a specific language to the issues that they're dealing with, and yet, you know, in a multi-faith family, you know, I'm open to you know, hearing the concerns and hearing the preferences of the non-Jewish spouse, family members, and such. And usually, again, you know, if they're speaking to a rabbi, there is a preference there. You know, in most interfaith families that I have encountered, a decision has been made of, you know, how the household will, which tradition the household will have. And so, you know, I have specific congregants who, you know, they're interfaith families, but they're congregants of my synagogue, meaning that they are preferencing the Jewish tradition in their household. And so I bring that, you know, that kind of language there. I haven't had a situation where I've had to, you know, do a funeral for a non-Jewish spouse of a Jewish member. And so, but I'm certainly open to that and open to catering to that, you know, within my own comfort level. I mean, there's certain words that I'm not going to say. There's certain prayers that I'm not going to use because I'm a Jewish practitioner. But even so, you know, you know, we you know, meeting people where they are, having the conversation, being open to their perspectives, while also saying, hey, I'm a rabbi and I'm coming from the Jewish perspective.
And Father Mario?
I basically agree with what Rabbi said. I would always assume that if someone is calling me that they're looking for a Catholic perspective or a Catholic support in the time of need that they have. But in terms of pastoral care, especially for our parishioners here, for the families that we have of mixed faith, and there's funeral services for someone at any stage of human development, we're always willing to, again, to meet them where they are and to incorporate another minister as best as we're possible into a Catholic ceremony. If it's, again, each family, as Rabbi said, if they're a mixed faith family, there's already have a set preference as to which faith they're following and what, you know, where they're going to church on Sunday, etc. But for us, if they are a mixed faith family and they want to attempt to integrate you know, the faith of another half of the couple into the funeral service or in the mourning process, we're happy to accommodate them. You know, just
we had this happen to us, Dr. Corey. We were kind of in a spot. It was an infant who was dying, whose parents were of different faiths, and they were in a relatively new relationship, and they really had not hammered out those decisions in their life and their marriage about what they were going to do. And we were at loose ends at first, trying to figure out how to meet those needs. So we ended up making it possible for each parent to spend some quiet alone time with the baby. So if there was a prayer that they needed to offer with that child in their presence, that they could do that. And that pretty much worked for us. But and we were kind of lucky that the way that the logistics kind of tumbled out is that there were moments when the mom was alone with the baby, and there were moments when the dad was alone with the baby. And we kind of in the moment kind of said, if there's something that you need to do for yourself, maybe now is the time for that. And it was hard and it was awkward, but looking back on that, I'm really glad that each one of those parents were allowed to have a few alone moment times with the baby.
I don't know, with this may be something Allison sees more than each of the faith leaders, because if they can't decide, they may just rely on the chaplain. Allison, is this something you've experienced fairly often, or how do you manage this?
I would say that I navigate a lot of family dynamics every day, and it's not always religiously based dynamics. It's language, it's cultural differences. It's so yeah, I feel like I'm flying by the seat of my pants sometimes, but there are some kind of basic tenets, like what Tammy brought up, that that kind of help me navigate those spaces. So one, it's just having, again, creating a safe space. So tell me, what is the most pressing issue right now? So if in the NICU, they just had rounds. Okay, so why are they calling the priest right now? What did they hear? So what is their fear and concern perhaps that got stirred in that rounds? I'm just making up that example. So trying to pinpoint what is exactly that they are in need of. So absolutely, if they want, the rabbi to come in and speak to this particular intervention or goal of care, then maybe we need to invite the rabbi into the goals of care meeting. Is it after death? Then is it about the mourning process and wanting the community from the mom or dad to be part of this? And how do we merge that, especially in COVID? I think we're having to be even more creative about meeting these grief needs in creative ways, right? So I'm not trying to be vague, but it just requires a lot of juggling. So for example, in terms of culture, because we're talking about culture as well, so there might be one member of the family who is Spanish speaking only, and the other member of the family is bilingual. Well, I don't want to put the pressure of putting that family member in a space where they have to translate for the medical team, but let them be that family member. So I might need to go get my in-person, and it takes some coordination, get the in-person translator, and then find out what it is that they need at that moment, and find the provider to meet that need. And sometimes, yes, I am creating a ritual for them. So for those that are, again, meeting those needs of spirituality, for those that don't, who have fallen away from the religious tradition perhaps, or are just on a journey where they need a ritual, but they're not connected. Maybe they just moved from out of state, let's say. So I had this wonderful rabbi, imam, or priest, back where I lived, but I just moved here. And so I don't know anybody. So either if I have time, I'll reach out to our directory. And if not, what can I do in this moment? Not pretending to be a replacement for the religious tradition, but what is it in this moment that might help?
Thank you. Well, I think we have no further questions, and folks are beginning to kind of ring off. I'd like to offer each of our faith leaders a chance for either a parting comment or message that they would like to convey to the group. So Iman, anything you would like to say in parting?
Yes, thank you very much. Wonderful opportunity. Thank you. I probably most like MCV and other hospitals, usually they have me in their chaplain's office. They have my contact information, but I'm happy to provide that for anybody who needs it. And you can always get me on email. It's Imam ICVA, Islamic Center, Virginia, at Gmail. Thank you so much. I really appreciate the opportunity to help you all out.
Well, thank you. And Father Mario?
Again, great thanks for inviting me here. It's been a great discussion. It's been great to meet all of you and talk with you and meet you virtually at least. And like Imam said, I'm happy to answer any further questions. And if I could be any assistance to all of you, just Dr. Dudley knows how to get a hold of me, and be assured of my prayers and support for all of you and the very good work that you're all doing.
Thank you. And Rabbi?
Yes, thank you. And as my colleagues expressed, thank you for having me. It was a great conversation, and happy to share our tradition and the ways that we provide comfort. And really, you know, our job is to in this case is to listen and to bring comfort and care. And any way that we can do that it's a blessing, and it's doing God's work. And so I'm happy to continue the conversation if anyone has any further questions for me. So thank you very much.
Thank you.
Thank you.
And Allison, you know, we were able to keep it a COVID-free zone until right at the very end.
Sorry.
We just had to bring it up.
The elephant in the room.
Anything you want to say from the chaplaincy perspective?
I would just say what a privilege to be part of this panel today. And thank you for everybody on the line. I see a lot of my colleagues, and I wish I could have had them answer some of these questions, because I depend so much on my community partners. All the nurses do so much of the memory making. We really need each other. And so I look forward to more conversations and collaborations with you all. Thank you.
Thank you. Well, thanks for all of you. Joe, do you want to wrap things up for us?
Yeah, I just want to thank everybody for taking the time out today just to be with us. And this was really amazing, telling us everything that we need to hear. And it was a great help for everybody, I think, to hear the different perspectives of things. Just hearing what you said, if we all start understanding how to approach families who are dealing and coping with death, be it mom or baby or anybody, if we all start thinking that way, then I think this summit was a great success from that standpoint. Before I part, Shannon just brought up a slide. First of all, I'd like to really thank Sabrina Munro. She came on to the VNPC not too long ago, and she's been a great help with our social media presence. She's keeping us all up to date. Some of us don't have any social media, and she's been really good with helping us with that. So we have the VNPC website, and we're updating that. So if you go on, you may see some changes, but they're not all there yet. We're also on Instagram, Twitter, YouTube, and we did have the hashtag VNPC and hashtag Virginia NPC. Also, as Shannon and Donald mentioned earlier, hopefully this will be our last virtual summit. Hopefully we can get back together in October. Nothing beats being in person and talking to each other in person. So hopefully we'll be then, our next summit will be in the fall. We'll send out a date soon. Until then, I hope everybody stays safe and take care. And if you have any questions or concerns, you can know how to reach us, please do. And thank you for everyone.
And real quick, thank you everybody. There'll be a survey at the end of this. It's 8 quick questions. If you could please just fill that out, just so we know how we can improve for next time.
Thank you, everyone.
Thank you, everybody.
Thank you.